I recommend micropulse laser therapy to a variety of patient types within my practice, but fundamentally, this is a treatment option for patients who are unhappy or uncomfortable on their current glaucoma medications and who are also uncomfortable with the idea of traditional glaucoma surgery, which may have higher risks. Many patients are appropriate for micropulse laser. Whereas some glaucoma treatments are limited to only mild, moderate, or severe glaucoma, this laser applies to all glaucoma spectrums, including patients who have not had surgery or have had surgery. So it's very versatile. I think it's on the table for anyone whose glaucoma is not optimally controlled.
The World Glaucoma Association is an independent organization that unites all national and regional glaucoma associations, reaching over 12,000 eye care providers in the world.
The WGA exists for the education and training of its members, as well as to advocate for its members as well as our patients.
The World Glaucoma Association, in one word, is togetherness. Togetherness in our work and our vision.
Staying connected with the glaucoma community is a key priority for the WGA. We welcome you to visit worldglaucoma.org, subscribe to our newsletters, and follow us on social media.
Wherever you are around the globe, welcome to the first webinar of the World Glaucoma Association Global Webinar Series. I am Fabian Lerner, President of the World Glaucoma Association, talking to you from Buenos Aires, Argentina. Today, we are joined by outstanding colleagues all the way from California in the United States, crossing many time zones through Canada, Brazil, Germany, and Spain, to Nigeria, India, China, and Japan. Our topic today is glaucoma surgery. I am pleased and honored to introduce the program chair, Professor Robert Weinreb, a founder and past president of the World Glaucoma Association, a skilled clinician, highly empowered scientist, and expert surgeon. Professor Weinreb is the chairman and distinguished professor of ophthalmology, director of the Shiley Eye Institute, and director of the Hamilton Glaucoma Center, all at the University of California, San Diego. Professor Weinreb.
Well, great. Thank you, Fabian, and greetings. This is truly a global meeting. We represent 6 continents. And I want to shout out in particular to our colleagues in India, my colleagues in the United States, Brazil, Nigeria, England, China, and Japan. These are some of the best attended countries for this first global meeting of the World Glaucoma Association. The program is a very exciting one. We decided to select glaucoma surgery as it's something that's impacting our care for all of our patients. We're going to be discussing standard glaucoma surgery. We're going to be discussing some of the more recent minimally invasive or micro-invasive glaucoma surgeries. The faculty is an exceptional faculty. We'll be going through the lectures, and then we'll have a discussion period at the end of all of the lectures in the first section. The sections are separated by an outstanding program that's been organized by Allergan, and a big thank you to Allergan, who is the sponsor of this program. And also I want to thank our partner, Entod from India, who has worked with us to produce this program. So without any further ado, let me introduce our chairs for the first section. First, let me introduce Neeru Gupta. Neeru Gupta is the professor at the University of Toronto. Neeru is a clinician, she's a surgeon, she's a scientist. Neeru does absolutely everything. She's been the interim CEO of the World Ophthalmology Congress, and she's newly appointed as the chief editor of the Journal of Glaucoma. Neeru comes to us from Toronto this morning. Neeru, welcome. I'd like to introduce next Remo Susana. Professor Remo Susana is the chair of the Department of Ophthalmology at the University of Sao Paulo in Brazil. Professor Susana is a past president of the World Glaucoma Association. He's among the most distinguished glaucoma specialists and glaucoma surgeons in the world. And Professor Susana, we're very pleased to have you here this morning chairing the session. And then third, I'd like to introduce Professor Ningli Wang, the third chair of the morning session. Professor Wang is perhaps the most distinguished ophthalmologist in all of China, glaucoma specialist. He's the former head of the Tongren Eye Hospital, one of the largest eye hospitals, if not the largest eye hospital in the world. He's been the president of virtually all organizations in China, as well as organizations within Asia. And Professor Wang, like the other chairs, is a clinician. He's a scientist, and he's also an expert surgeon. So Professor Wang, welcome, and welcome back from vacation to all of our Chinese colleagues. We understand you had Golden Week and you returned to your offices and your homes sometime during the past day. It should be a great meeting. It's a good adventure, takes us away from some of the COVID-19 activities or lack of activities that we've had. Without further ado, I'm going to turn the program over to Neeru Gupta, who will introduce our first speaker.
Well, thank you very much, Bob. Welcome to everyone, wherever you may be. And I'm speaking from Toronto, and it's my great pleasure to introduce our very first speaker, Professor Esther Hoffman. Professor Hoffman is head of the Glaucoma Department of Ophthalmology in Mainz. She's head of the Childhood Glaucoma Center in Mainz. She's an internationally recognized clinician who does science that is clinically relevant and is very well known for her expertise in glaucoma surgery, both in adults and children. It gives me great pleasure to ask her to tell us why there is nothing like trabeculectomy for glaucoma surgery. Thank you, Professor.
Thank you, Neeru, for these wonderful words, and thank you, Bob, for the introduction. So I will try to share my slides. Do you see them? Is it visible for all?
Yes.
Okay,
Yes.
wonderful. Okay, great. So I will start with an important topic, I think. So there's nothing like trabeculectomy for glaucoma, and I hope I will convince you at the end of my talk that trabeculectomy is the best surgery you can do for your patient. So when I searched for the term trabeculectomy in PubMed, I was really surprised that there are really lots of manuscripts on trabeculectomy. So this method still seems to be very popular. And I will show you on the next slide, and hopefully it will work, that this is really a very nice method to do. Unfortunately, music is not playing, but look at this bleb forming at the end of the surgery. Isn't this wonderful? So great surgery, but is there also literature out there? And yes, there is literature. So is trabeculectomy still up to date? And I brought you this multi-center analysis, which I really like, about 400 patients from England, and they were followed up for several years. And the authors found a success rate of 80% without medication, which is a very high percentage of successful performed surgery. But as you can see here in red, they emphasize the intensive, proactive, post-operative follow-up. And I mean, this is really well known that the surgery alone is not the only important part, but the follow-up is very important also. To show you the next slide. So what about comparison of the trabeculectomy to other techniques? And I know especially in the US, primary tubes or tubes in general are really popular. So we found the primary tube was a trabeculectomy study, very interesting. And this year, the 3-year results came out. But still, as you can see on the slide here down in the graph, after 1 year, the intraocular pressure in the trabeculectomy group is still greater than in the tube group. And at the end, also at the end of 3 years, there were fewer medications in the trab group. So in my opinion, why making a tube when it is not better than a trabeculectomy? It is more expensive, at least in Germany, longer surgery time, you have a foreign body, the IOP is less lowered, and there's more medication required at the end. And revision, you all know that a needling procedure versus an open revision in capsule opening, it's more laborious. So I hope to give you 4 keys to success for trabeculectomy. And we start with the first key to success when you do trabeculectomy. And this is the patient. So choose the right patient for your surgery. Don't choose the one that is 95 years old, hyperopic, has a very small eye, and is a very anxious patient. Explain the procedure to the patient and create confidence. This is very important when talking to glaucoma patients in general, and provide a good feeling for the patient and also for you, that you are convinced from your surgery you're going to do. The next key to success is the white conjunctiva. As you all know, and we all know, that the long-term antiglaucomatous medication leads to chronic inflammation of the conjunctiva. We should stop the antiglaucomatous medication prior surgery, 2, 3, or 4 weeks prior to the trabeculectomy, and put the patient on preservative-free steroids, dexamethasone, 1 week prior surgery, depending on the blepharitis or the inflammation symptoms. And then it's your turn, the surgery itself. So be careful when performing trabeculectomy. Be careful with the conjunctiva. Don't touch it too much. Use mitomycin C and wash it out extensively. It is always helpful to be an experienced surgeon who can manage complications, especially intraoperative complications. And if you want, you can adapt the sutures. You can use releasable sutures if required. The last key to success is the post-operative period, and this is very, very important. So you should apply 5FU early and assess bleb morphology. So, for example, evaluate the appearance of the bleb. Is it diffuse? Do you see microcysts? Is it very prominent or not? And perform suture lysis or remove sutures if applicable. give lubricants during this period post-operatively up to several weeks, and intervene appropriate and timely in case of complication. So to summarize, there is no better surgery than trabeculectomy for the right chosen patient. Please talk to the patient, explain what you want to do, and take care of the ocular surface preoperatively. A wide eye is the clue for success, and the overall success is highly dependent on postoperative treatment and management. Thank you very much.
Esther, thank you. And I want to remind the speakers to stop screen sharing after your presentation. Remo Susanna will introduce our next speaker, Professor David Greenfield. Remo?
Yes, thanks, Bobby, for introduction. It's a pleasure to introduce David Greenfield. David Greenfield is professor of ophthalmology, Douglas Anderson's Distinguished Chair in Ophthalmology, and the Vice Chair at the Bascom Palmer Eye Institute in Miami. He is a past president of the American Glaucoma Society and has taught and published widely in all aspects of glaucoma. Today, he will answer the question, are glaucoma drainage devices the new gold standard? Professor David?
Well, thanks very much. Remo, good morning, good afternoon, depending upon your time zones. This is a fantastic collaboration, and I'm delighted to participate in it. I've been asked to discuss the question, are tubes the new gold standard for glaucoma surgery? My disclosures are listed here, and the only relevant one is I serve as a consultant to Allergan, the sponsor of this webinar. I'm not a fan of the term gold standard, and I want to draw your attention to this editorial published in a plastic surgery journal recently, which really nicely underscores some of the problems with the terminology gold standard, namely that no two surgeons can actually produce the same outcome with a single operation. No two patients are alike and likely to achieve the same outcome with the same operation. And I'll say until recently, there have been relatively few well-designed, controlled, randomized surgical trials. Be that as it may, I'll still refer to the term gold standard, knowing that there are significant limitations to the phrase. And since 1968, as Esther Hoffman really elegantly pointed out in her presentation, a Cairns-style guarded filtration operation, as illustrated on screen left, has really been the typical reference or gold standard for patients with moderate to advanced glaucomatous nerve damage and visual field loss. Over the last decade, the question has emerged whether or not a tube shunt or a glaucoma drainage implant or an aqueous drainage implant, all of which are referring to the same surgical procedure, could be a new gold standard. And as you see in this slide, when performed appropriately for the right patient, both of these procedures can achieve highly successful results. The problem is that there is a high proportion of complications with both of these procedures. And I'm showing you here on the left, the types of complications that are not uncommonly seen after trabeculectomy, including a dysfunctional bleb, infections including bleb-related endophthalmitis and leakage, and hypotony-related complications including choroidal effusion and folds in the macula. Drainage implant surgeries are not immune from having a high proportion of complications, including restrictive motility disorders and double vision, exposures of the drainage tube, corneal edema, and hypotony-related complications, including spontaneous explantation of the device as seen on the bottom right. Well, What would a gold standard surgical procedure look like? And many of us are familiar with the terminology introduced by Professor Kahl, the 10-10-10 procedure. Described by Professor Kahl, this is an audacious goal in which we would try to achieve a surgical procedure that could be performed in 10 minutes, achieve a postoperative pressure consistently of 10, and survive for 10 years. And I'll add to this audacious goal that it should have the same safety profile as a standard phacoemulsification surgery. Another way to approach whether or not we have a new glaucoma surgical trend is to actually see what our colleagues are performing. And this is data that was published by one of my fellows, Sid Rathi, in collaboration with a group from Michigan led by Joshua Stein, in which we looked at 1,400,000 Medicare beneficiaries for almost a decade to determine what were the surgical trends that our colleagues are performing. We also examined who were performing these procedures. Were they glaucoma specialists or non-specialists? Not surprisingly, on the left, we see that filtering surgery is on the downswing, and that over this time period, there was a 26% reduction in the proportion of trabeculectomies performed, compared to drainage implant surgery, in which there was a 20% increase in the amount of drainage implant surgery performed. I'll draw your attention to the year 2012, during which time most of these trends seem to have shifted. If we look at some of the surgical procedures that Bob Weinreb alluded to, the microinvasive glaucoma surgeries led by the iStent during this time frame, you see that there was an explosive increase in the proportion of iStent surgical procedures. And on the right, if you look at the proportion of these procedures overall performed by specialists in blue compared to non-specialists, why it's very clear that specialists are performing traditional glaucoma surgeries, where 75% of the time, procedures such as iStents and other MIGS procedures are being performed by non-specialists, at least the way we defined it in this surgery. It's well known that drainage implant surgeries have traditionally been reserved for the so-called high-risk glaucomas, and those include uveitis patients, eyes with neovascularization or eye syndrome, or eyes that have failed prior filtration surgery. But as I mentioned, in 2012, a new era had emerged with the publication of the 5-year data of the randomized controlled trial tube versus trabeculectomy or TVT surgery. And in this surgical trial led by Steve Getty, which was a fantastic, well-designed study with 87% retention at 5 years, you can see that the intraocular pressure at 5 years was statistically similar between both groups, yet there was a much higher rate of surgical failure in the eyes that had undergone trabeculectomy, averaging 50% at 5 years, compared to those eyes with drainage implant surgery averaging 30% at 5 years. You can see that there was a significantly higher rate of reoperation in the trabeculectomy group, and one sees that the quality of life scores were similar in both surgical procedures measured at 5 years. So clearly, perhaps a new reference standard has emerged, certainly in eyes with primary glaucoma, including open and closed angles. But there's other patients in whom one might consider a primary tube shunt surgery, including those eyes with high axial myopia or who wear contact lenses. These eyes are at significantly higher risk for complications with trabeculectomy. Because there's fewer postoperative visits with drainage implant surgery, perhaps eyes with poor compliance with their postoperative follow-up or with their postoperative corticosteroid use might also be good candidates to perform primary surgery. And indeed, as I mentioned, there are fewer postoperative visits. But not so fast. If you look carefully at the design, the methodology of the TVT study, there were design flaws. and there was a bias against trabeculectomy surgery by enrolling eyes that had previously failed a trabeculectomy. There was not only a very high concentration of mitomycin C used, but also a significantly longer duration of time of 4 minutes compared to what is typically employed now. And eyes that had a pressure of 5 or less were considered a failure. And as we know very frequently, those eyes can be considered highly successful with 20/20 vision. Furthermore, many eyes with open-angle glaucoma who progress at low normal pressures can achieve a low enough target pressure with a tube shunt surgery. We know that typically these patients will require multiple medications, so eyes with multiple medicine intolerance are poor candidates. And it may not be generalizable, as you heard from Professor Hoffman, to primary filtration surgery. And I won't repeat this. This was nicely reported by Esther, the 3-year TVT primary study that was just published in Ophthalmology. So in summary, it's very important that surgical decision-making be individualized. One must consider the stage of glaucomatous damage, the target pressure that one is seeking, and whether or not secondary mechanisms exist. Tube shunts are more likely to be successful in eyes at high risk for surgical scarring or prior surgery or high myopia, but tend to be less successful in eyes when performed as a primary surgery compared to trabeculectomy. Thank you very much.
Great lecture, David. Thank you very, very much. Want to shout out our colleagues in Nigeria. We have a great group attending the meeting today from Nigeria. Welcome to the global glaucoma scene. Professor Ningli Wang will introduce our next speaker. Professor Wang?
Yes, I'm here. First of all, thanks Dr. Warren for inviting me attend the fantastic meeting. Next, I'd like welcome Professor Custer from the University of the Cabinet. He is the director of the glaucoma service and the director of the postgraduation in ophthalmology. He has been involved in the research of the diversity field in the glaucoma, has received 20 awards, including the senior awards from the AAO, and he is the former president of the Brazilian Glaucoma Society. Please.
Well, thank you very much, Ningli. I would like to, first of all, thank the Glaucoma Association, the World Glaucoma Association, Bob Weinreb and Fabian Lerner. My mission here is to talk about transscleral cyclophotocoagulation. Is it here to stay? These are my disclosures. Well, we all know that the continuous mode of cyclophotocoagulation is an excellent option in eyes with refractory glaucoma, with a fibrotic conjunctiva and poor visual acuity. Technically, it's a very easy procedure. The postoperative care is smooth, but there have been reports of long-term complications. Some of them very frequent, such as anterior uveitis or even conjunctival burns and pain, but mainly loss of visual acuity secondary to cystoid macular edema. Some of them are less frequent, corneal edema, choroidal detachment, hypotony, but the worst of them, no doubt, is phthisis bulbi. Well, micropulse technology has recently become available. It's also a transscleral procedure. It uses laser energy, however, for only 0.5 milliseconds, followed by a rest of 1.1 milliseconds, a duty cycle of 31.3%. The result is that you deliver less heat to the ciliary body and promote less damage to the ciliary body. We normally treat 80 to 160 seconds per hemisphere and a fixed power of 2000 milliwatts. This interesting study by Musa shows the histologic changes following continuous wave and micropulse CPC in cadaver eyes. In terms of macroscopy, continuous CPC leads to well-circumscribed white spots in the pars plana. However, on the other hand, micropulse CPC causes only linear streak-like depigmentation in the pars plana. Microscopically, Continuous CPC may cause splitting within the ciliary body epithelium, separation between the ciliary body epithelium and the stroma, coagulation and destruction of the stroma, and finally destruction of the whole ciliary body epithelium. Micropulse CPC, on the other hand, causes only splitting within the ciliary body epithelium. There has been a lot of discussion on the mechanisms of action of micropulse CPC. Some suggest a subthreshold damage to the ciliary body epithelium, leading to a decrease in aqueous humor production. Others suggest extracellular matrix remodeling in the ciliary body, leading to increased uvoscleral outflow. And finally, some suggest ejection of the scleral spur, as shown in the video, a pilocarpine-like effect, increasing conventional outflow. The technique I do this procedures under propofol. No lead speculum is used. We do it with methylcellulose between the probe and the conjunctiva. And the idea is to move slowly from 3 to 9 o'clock, about 15 seconds between 3 to 9 o'clock. The patient leaves the OR without a patch using anti-inflammatory drops. This study here compares continuous to micropulse CPC, but the study published in 2015, preoperatively pressures were similar, 36 and 35, coming down to 20 and 19 after 18 months. But what really shows this is the study here is the difference between the incidence of complications. You can see hypotony, visual acuity loss, prolonged inflammation, and phthisis were more frequent with continuous wave CPC compared to micropulse. The studies published until 2018 show an effectiveness that can vary from 26% to 59%. Also, reduction in the number of medications from 0.48 to 1. We recently published a series of 21 cases with refractory glaucoma, mainly neovascular glaucoma here, using the same technique with a mean treatment time of 178 seconds. After 1 year, there was a decrease in intraocular pressure from 33.4 to 18.9, and a decrease in number of medications from 3.5 to 1.9. Defining success as intraocular pressure between 6 and 21, and an intraocular pressure reduction of 30%, we obtained a success rate of 66.7% at 1 year. 33%, 1/3 of the patients required retreatment. We had prolonged inflammation in 4 cases, hypotony in 1, and visual acuity loss in only 1 individual with neovascular glaucoma. We didn't have macular edema or lens opacification. This is another interesting study by Fabian Lerner, a retrospective study with 22 eyes. And the interesting thing of this study is that it shows that the success rates vary according to the exposure time. You can see this eyes that received only 100 seconds mainly didn't have a success. The success rate increases to 21% with 160 seconds and 75% with 180 seconds. This other recent study investigates the effectiveness of this procedure in eyes with good visual acuity better than 20/60. 15 eyes of those were undergoing primary glaucoma procedure. Energy levels were 2,000 milliwatts for 160 seconds. Patients were followed for 10 months. Pressures reduced from 25 to 15, and the number of medications reduced by 0.82. But if we define success as intraocular pressure between 6 and 21, or an intraocular pressure reduction greater than 20%, without the loss of visual acuity, this authors found a complete success rate at 12 months of 75%, increasing to 93% when visual acuity loss was allowed. Now, if we take a look at the complication in these cases, we'll see cystoid macular edema happening in 3% of those patients, cataract progression in 40%, and visual loss in 20% of these individuals. In conclusion, I do think micropulse CPC is here to stay. It's a relatively safe and effective technology. It is associated with less damage to the ciliary body. It is associated with less vision-threatening complications than continuous CPC, which leads to expanded indications of this procedure. However, indicating micropulse CPC as a primary procedure is not ready. We still need more large prospective randomized clinical trials in order to use this as a primary procedure. Retreatment may be necessary in some cases, and we also need more studies to establish the energy level that achieves better efficacy and safety balance. Thank you so much.
Great, thanks, Vital. We're already receiving a large number of questions from all of you, 2,500 of you. If you do have questions, you can place them on the chat. And obviously we won't be able to get to all the questions, but we will attempt to get to as many as we can. We're running right on time. And I'm going to turn the program now over again to Neeru Gupta, who will introduce the last speaker of the session. Neeru?
Thank you, Bob. Well, it gives me great pleasure to introduce our next speaker, Professor Tanuj Datta, who is in India with us now. He's the professor of ophthalmology at the Center for Ophthalmic Sciences at the All India Institute of Medical Sciences in New Delhi. He has really served internationally. He is on the board of directors of the Asia Pacific Glaucoma Society, also the International Glaucoma Surgery Society, and he's been a big part of the World Glaucoma Association, having served as the senior chair of the Associate Advisory Board, and also is currently associate editor of the Journal of Glaucoma. He's widely published, has done several innovations in glaucoma surgery, and is well known to us all. It's now time to hear, is it glaucoma drainage device or trabeculectomy or cyclophotocoagulation? Tanuj?
Thank you very much, Neeru and Bob. So warm greetings from New Delhi. Before I start, I apologize in advance to David and Vital Costa. Esther is safe. I have no financial disclosures. So coming to the topic of which is the better surgery, tube, CPC or trabectectomy for a glaucoma patient, the two important guiding principles are, first, do no harm, the Hippocratic Oath. And secondly, if you want a surgery, it must be global. And remember, 50% of the world's population live on less than $5 a day. And this is becoming worse with the COVID epidemic. Now, I'm not able to understand why people are advocating tubes at primary surgery. You can see this aesthetic drawing on the eye. So should a tube replace a trap? If you see the results of trabectectomy versus the Ahmed glaucoma valve at 5 years, trabectectomy gives a much lower intraocular pressure and has a much higher success rate as compared to the Ahmed glaucoma valve. And of course, we have seen in the primary TVT study that trabectectomy leads to a much higher success rate and a lower intraocular pressure as compared to the Barwell implants. So the IOP lowering efficacy of trabectectomy is much better than tubes. An important thing to understand is that tubes lead to a corneal endothelial decrease, and the patient may have IOP control but corneal decompensation. So you have to plan for a subsequent corneal surgery, and we already have a scarcity of corneal tissue in developing countries. Furthermore, you can decrease the quality of life of the patients with the Barwell implants because there is a high incidence of binocular diplopia. So you may have to do a strabismus surgery after glaucoma surgery. But my main problem with the tubes is, if you see the Medicare data, the sight-threatening complications of the tubes are 3 times higher as compared to trabectectomy, and they keep on increasing over time, especially the suprachoroidal hemorrhage and the endophthalmitis. And if you see the Ahmed Barwell comparison study, the sight-threatening complications are much higher with the Barwell implants, including phthisis bulbi. So if you take the principle of do no harm, I think the Barwell implant does not pass the test because you have a procedure which can lead to loss of light perception and hypotony and phthisis. So that I feel is not acceptable ever as a modality of primary surgery. So trabectectomy is definitely better than tubes in terms of safety. And furthermore, if you compare the cost effectiveness of trap versus tube, the trabeculectomy is definitely more cost effective as compared to the glaucoma drainage devices. So I would say you should say no to primary tubes. You have a limited conjunctiva. You always have to anticipate and plan for future surgery. So don't start off with a tube. And furthermore, tubes definitely have a higher cost, more serious complication, and a less IOP lowering capability. And what do you do if your tube fails? So if you do a second tube after the failure of the first tube, you can see this comparison study. The complications are 60% with a reed tube as compared to a CPC with 11% endophthalmitis. So putting in a second tube is not a good option in terms of safety. So why not replace trabeculectomy with a CPC? So Vital mentioned about the primary CPC. I'm not concerned with the sight-threatening side effects. This study from Ghana showed that with a DLCP with a low parameters of 1.5 volt, nearly 30% of patients had atonic pupils, and remember, they have a bright sun. So comparison of one eye trap and other eye CPC in the same setting showed that trabeculectomy has twice as higher success as CPC. So CPC cannot replace trabeculectomy as a primary surgery. Now, what about the new micropulse laser? So currently, it's a very high cost single-use probe. It is being marketed as a IOP lowering efficacy with excellent safety and efficacy as primary therapy, and especially during the COVID-19 pandemic. There are a lot of studies. I chose the most recent one ahead of publication from Journal of Glaucoma. So definitely you have a IOP lowering. The success rate of single treatment is 36.5%. So micropulse definitely lowers IOP in the short term, but half of the patient required additional intervention, and mydriasis in 11%, 15% loss more than 3 lines of Snellen acuity. My main problem with micropulse is there is no consensus on what is standard therapy. So people just follow whatever the company parameters are put up, but you cannot have one energy protocol, one size fits all is not appropriate because eyes with higher pigmentation require lower energy levels. And coming to the safety issues, if you do a micropulse laser and you get a subconjunctival hemorrhage, you can get a laceration and thermocoagulation, and this can lead to conjunctival scar formation that can offset a future trabeculectomy surgery. A lot of glaucoma patients have ocular surface disorders. And with micropulse laser, because you are painting the perilimbal neural plexus, you can end up with neurotrophic ulcers. So please check the corneal sensation before you do micropulse laser in your patient. And I thought I could do this in patients who are not systemically stable. They have systemic issues, but micropulse laser can precipitate suprachoroidal hemorrhage, and patient can have a lot of loss of light perception due to hypotony post-laser. So it is not good for patients with multiple systemic problems, and especially don't use it if the patient is on anticoagulant. So whatever may be the different mechanisms, I believe MP3 is just a gentle CPC. It has a potential to moderately lower the intraocular pressure at a very high cost. It is not a long-term global solution for IOP control. It cannot achieve a low target intraocular pressure. You have significant sight-threatening problems, and you are breaking down the blood-aqueous barrier and destroying the pupil integrity. So trabeculectomy, in my opinion, remains the gold standard. The only important thing is to use a lower dose of mitomycin C to decrease the post-operative complication. You can see after a decade of follow-up, low IOPs can be achieved. And if the trabeculectomy fails, don't worry, you don't have to put in a tube. Very nice study from Michael Coote. You can just do a posterior revision of the bleb, and for another 5 years, you can get a good IOP control. So if you want to achieve a global goal for a WGA universal glaucoma surgery, of course, it's okay to have 10, 10, 10, but you must keep in mind that unless you have a $10 cost of glaucoma surgery, it is not going to take care of the global glaucoma problem. So trabeculectomy is definitely the gold standard. Thank you very much for your kind attention.
Well, thank you. I'd like to invite the chairs and the speakers to a discussion. We've received a large number of questions, and I think they're quite interesting. The first series of questions, I'd like to invite Esther Hoffman, but of course, we want to hear from everyone. And I would ask you, if because of the time limitation, to keep your answers succinct, try to keep them under 30 seconds. So there's a great question about the role of 5FU. You know, 5FU has been a standard for many, many years. Is there still any role for the use of intraoperative 5FU now that we have mitomycin? Esther, are you there? Do you want to help us?
Yes, I am here. Hi. So since we use the MMC and we have good results, I hear myself double. So I believe that there is no sense for 5FU intraoperatively anymore at the time when using.
So I'd like to ask others for their opinion. For example, in a patient with high myopia, is there any role for intraoperative 5FU? Anybody want to comment?
Sure, Bob, I can comment. I can tell you it's uncommon for me to use intraoperative 5FU, but in the case that you're describing, which we see frequently, who needs a trabeculectomy, I think the safety profile of 5FU is safer than the safety profile of even a shorter duration of mitomycin C, and it's absolutely reasonable. It's not a common procedure that I perform, but in select instances, I think it's a good one.
And of course, one of the nice things about 5FU is the effects are largely reversible, unlike mitomycin C. And that brings us to the next question with 5FU, which is the use of postoperative 5FU. So you're performing your trabeculectomy with mitomycin C. Is there any role for the use of a postoperative injection of 5FU? Comments? Esther?
Well, I can just tell our standards we use, and we have success with that because our 10-year data also show that the use of at least, 3 to 5 5FU injections post-operatively, additionally to the mitomycin, keeps the pressures over time in a very nicely lower teen. So that's our experience. So yes,
Great.
we.
Niru, any comments? Do you use postoperative?
I think it's less commonly used for sure in my practice now than it used to be, but there are definitely cases where in the post-op course of the early post-op course where the eye looks angry, there looks like it's going to be, we're looking at some scarring coming up. I find that the supplemental 5FU in that post-operative course, again, 3 to 5 injections can help in the long run, and that's been supported by a number of studies, as Esther mentioned. So I do find it useful, not commonly, but it's a useful tool to have.
So two other scenarios that I think 5FU postoperatively are useful. One of them is obviously in a patient following a needle revision, where post-op 5FU I think is very critical, especially in the first 3 weeks. And then the second is in eyes following a clear corneal phaco that had a prior mitomycin C trabeculectomy. I think it does reduce the rate of postoperative scarring.
David, you have a failing trabeculectomy, and you talked about needle revision. You know, I used to perform these largely in the clinic at the slit lamp, but increasingly I'm bringing the patients to the operating room where I have greater control and I'm under higher magnification. Can you comment? What are you doing?
I'm still doing them in the clinic for most of my patients. I do it from a ab externo approach using a 27 gauge needle. I think in pseudophakic eyes, I really will make a significant attempt to try to enter into the anterior chamber. And in phakic eyes, I will avoid doing that. I remember Brad Shingleton does your approach from a meeting a number of years ago, and in fact will often go from an ab interno approach to try to needle from within the anterior chamber. But I typically do it in the outpatient setting at the slit lamp.
Great. Niru referred to the angry eye. An angry eye for me is often an eye that's very hyperemic and has a lot of cells and flare within the anterior chamber after trabeculectomy. And those are the eyes in which I, will consider an injection, subconjunctival, subtenon's injection of 5-FU. Let's move over to the tubes. David, you spoke about tubes largely generically, and I'm wondering, what tubes are you using, and are there differences among tubes, and are you selecting a tube based on the individual patient?
Great question. Thanks for bringing that up, Bob. So yeah, I did speak rather generically about tubes. We all know that they come in different flavors, namely the valved types of tubes, such as the Ahmed valve, and the non-valve devices. Most commonly being used are the World Glaucoma implant, but others exist, including the Maltino 3 and other kinds of implants as well. So traditionally, I do not use a Barvelt 350 device. That's the device that was utilized in the TVT study, but rather I use the smaller device, the 250. I don't even think the 350 is commercially available now. And as you point out, there have been some good studies. Some of the speakers have highlighted them, comparing the Ahmed FP7 valve and the 350 Barvelt. And I think Tanuj nicely showed that there's a lower pressure, lower requirement for medications with Barvelt implants. However, there is a very high rate of postoperative sight-threatening complications associated with that device. So you have to select the right device for the right patient. And for example, in patients with uveitis or prior cyclodestructive procedures, those are the types of patients I might favor using an Ahmed valve over a 250 Barvelt.
Right. Any experience with the Ahmed ClearPath?
None.
Right. So the ClearPath, I think, is a very nice improvement on the prior Ahmed. It has a lower profile. The little eyelets extend anteriorly. And it's a device that we've been using preferentially. Anybody have experience with that at all? Great. So let's talk about laser diode cyclophotocoagulation. And, there's a terrific editorial by Harry Quigley that was published just a few months ago. I don't know if anybody saw it, but he makes a very compelling case about being careful using a procedure like micropulse laser diode cyclophotocoagulation because of the limited studies that have been done to demonstrate efficacy. And as was pointed out in the lecture by Tanuj Dada, we just don't even know there's no consensus on what's the best way to perform these procedures. We recently discovered, for example, that with a new probe that is offered, that the power to get any effect has to be considerably higher than what we had been using before. Tanuj, do you want to comment on that? Have you seen the wonderful editorial by Harry Quigley?
Yes, I went to the editorial, and I think we have to be very cautious in adopting these technologies, and especially as a primary surgical modality for open angle glaucoma. They're okay if you have a failed trap or a failed multiple surgeries, they're fine. But putting them ahead of that is fraught with complications. The issue is that the ciliary body anatomy varies from patient to patient, and the pigmentation varies from patient to patient. So if you're having the same energy for an American patient, African patient, Indian patient as advocated, it is not okay because you're going to have significant inflammatory problems. So I think it's a modality which can reduce the intraocular pressure modestly, short term. It's not something that is going to take care of glaucoma in a long-term basis. And I also worry that if you have a permanent mydriasis, so where you have a bright sun, that is another very serious complication that there is no cure for that. So let us wait for more randomized controlled trials before we adopt this new technology.
Vital Costa, question about the having to repeat micropulse laser. A number of surgeons find that they need to do the procedure more than once, more than twice, sometimes 3 times or more. And more often than they would with standard laser cyclophotocoagulation. Can you comment on that?
Yeah, Bob. It is true. We do have to repeat it sometimes. In my study, about 33% of the cases. But, I'd rather do a less aggressive procedure that might lead to less damage to the ciliary body long-term than to do a more aggressive and be afraid of complications such as hypotony or phthisis. So what I tell my patients whenever I propose this procedure is that, well, we're going to be doing this, but it is very frequent that you require another one. But let me come back just a few seconds to what Anuja said. I think it's very important. I don't think we should recommend this procedure as a primary procedure right now. We don't know safety, long-term safety for this procedure, and we don't know whether the parameters that we use are the best ones. I think we still need to study a little bit more the ratio between laser energy, safety, and efficacy.
Yeah, and again, and just a caution, if you're switching probes, don't assume that the same parameters with respect to power are going to translate to any new probe that you use. So question about hypertensive phases with glaucoma drainage device and cysts. David, do you want to comment? What can you do to, first of all, avoid the hypertensive phase that is often seen? And secondly, if you do get a hypertensive phase, what are you doing to ameliorate it, treat it?
Well, there's no question that a hypertensive phase exists in a subgroup of eyes using any kind of device, particularly those eyes that are more prone to developing postoperative scarring. I like the term hypertensive phase because it's not a negative phrase. Patients like it because it seems temporary, and surgeons like it because it doesn't sound like your operation failed, even though in a large proportion, it's an indication that your surgery has failed. It's kind of like, instead of using a word needling, I use bleb enhancement, like our refractive surgeons. So the hypertensive phase tends to exist in a subgroup of people for up to 6 months. I put them on a low-dose corticosteroid to try to inhibit postoperative scarring, such as Lotemax. I'll adjust the medications accordingly. I avoid needling the bleb. But as I mentioned, it's frequently a permanent problem and can be a challenge that often does not necessarily reverse itself, even after 6 months of observation.
And how do you decide whether it's a hypertensive phase or just a failing glaucoma drainage implant that needs something else to be done?
It's very hard. That's why I said it, it definitely makes the surgeon feel better to call it that. But after 6 months of observation using aqueous suppressants and low-dose corticosteroids, I think at that point, if you still haven't achieved an adequate amount of pressure reduction compared to the pressure you were at preoperatively, I think one can safely assume that the operation has not been successful.
Great. One last question before we move on, and it's a good question. Anybody with experience with mitomycin C and glaucoma drainage devices? And I'm going to direct that question to Remo Susanna. Professor Susanna, are you there?
Yes.
Professor Susanna taught me a lot about the use of glaucoma drainage devices. And I remember a number of years ago when I was visiting him in Sao Paulo, he was talking to me about his use of mitomycin C with glaucoma drainage devices. Remo, you still using mitomycin C? Do you want to comment?
We did a large research in Latin American Glaucoma Society, multicentric, using mitomycin C and a group and the other group, a control group, without mitomycin C. There is no advantage to use mitomycin C with the glaucoma drainage device. On the other hand, you may have more complications. So there is no way to use mitomycin C with the GDD.
Great. I think that's the most experienced. The late George Alvarado from San Francisco. A very careful surgeon, a very careful investigator, he was convinced that mitomycin could successfully supplement glaucoma drainage devices, and I think it still awaits large studies. Professor Wang, Ningli Wang, can you comment on what you're doing with glaucoma drainage devices and the experience in China?
So in some doctors also like to use mitomycin C subcutaneous to use that. But in some doctors don't like. But unfortunately, so far, we haven't any studies on this topic. So we cannot get the conclusions to use or don't use the mitomycin C when we perform the GDD. So we did not get the conclusions.
Great, thank you. Well, I want to thank our speakers and our chairs. This was a great session. We're going to move on. We're right on schedule. And I want to introduce Ramin Valian from Allergan. Ramin, are you there?
Yes, I am. Good morning.
Great. So again, a big thank you to Allergan, who had the courage to sponsor this first webinar, not wondering whether we would have, at least I was wondering whether we would have 50 people attending, but we have 2,500 people attending. Ramin is the vice president at Allergan. Allergan has recently undergone, changes once again. Ramin will tell us a little about that. He's someone who has a long experience in ophthalmology, and we're very pleased that Ramin is working, in the glaucoma space and interventional surgery. He'll tell you a little about Allergan, and he'll introduce our next speaker, Jonathan Myers. Ramin?
Great. Thank you so much, Dr. Wainwright, for that kind introduction. First, I want to thank the World Glaucoma Association in partnering with Allergan to conduct this session. We've had a very long-term history with the WGA for many years and look forward to continuing that collaboration. I also want to especially thank and acknowledge Drs. Weinrap, Lerner, and Lin for their continued support. As Dr. Weinrap mentioned, Allergan has been a leader in eye care for over 70 years with over 125 product launches helping millions of patients. Most recently, as many of you know, Allergan became a part of AbbVie organization. We're now the 4th largest pharmaceutical company in the world. I'm delighted to let you know that our commitment to eye care remains, including keeping the name Allergan Eye Care within the organization. So you'll expect to see more investment and more collaboration from Allergan as part of AbbVie in this new organization. Now, over the years, we've had many innovations under our belt, and most recent innovation that we've had is the launch of the world's first biodegradable implant for the management of IOP in ocular hypertensive and open-angle glaucoma patients. Durista, which is the brand name of this innovation, was launched in the US in March of this year. Now, Durista represents the first innovation in drug delivery, which demonstrates 24/7 drug release targeted to disease tissue, consistent IOP control over time, while bypassing the ocular surface with a proven safety profile and is well tolerated. Please keep in mind that Durista is only approved in the United States. Ongoing trials are going in the rest of the world for registration.
And again, I want to thank Allergan. Allergan has been a great supporter of the World Glaucoma Association from day one. And I want to thank Ramin Valian, Matt Bolton, and the team at Allergan for their continued support of the World Glaucoma Association. And with that, I'd like to move on to our next session, where we're going to be discussing some of the newer surgeries, including the minimally invasive glaucoma surgeries. Thank you, Jonathan.
Thank you.
Let's bring on our chairs. I'll introduce the next series of chairs that we have here. And I'm going to begin with Jeff Liebman. Jeff is widely known internationally. He's professor of ophthalmology. He's vice chair at Columbia University in New York. Jeff is a consummate clinical researcher, and his work has addressed so many important areas in glaucoma, including how drugs work. And more recently, in particular, he's very interested in diagnostic technologies and the paradigms for earlier diagnosis and detecting progression of disease. Jeff is a former president of the American Glaucoma Society. He's a former president of the World Glaucoma Association. Jeff is a wonderful collaborator, and it's wonderful, Jeff, to have you here as a chair. I'd also like to introduce Osula Olawaye, and she joins us from Nigeria. She's a glaucoma specialist. She's a senior lecturer at the Department of Ophthalmology in the College of Medicine at the University of Ibadan. She's also the secretary of the Nigerian Glaucoma Society, and she's a member of the Board of Governors of the World Glaucoma Association. Welcome to you. And then last, I'd like to introduce Makoto Aihara. Makoto Aihara is a physician scientist. I can tell you he is a very skilled surgeon, anterior segment surgeon, glaucoma surgeon. He's the professor and chair at the University of Tokyo, and his research really ranges from the front of the eye, where he's described the techniques for performing anterior segment aqueous dynamics in murine models that have been adopted, throughout our experimental testing, as well as his work in understanding biologic mechanisms of outflow, and more recently, understanding mechanisms of neuroprotection. So Professor Aihara, it's very late in Tokyo right now, but thank you very much for taking time from your busy schedule to join us today. And with that, I'm going to turn the meeting over to Professor Jeff Liebman, who will introduce our first speaker.
Thank you, Professor Weinreb, and congratulations to you, to Professor Lerner, and the entire World Glaucoma Association for putting together this meeting and allow us all to connect during these unusual times. It's my pleasure to introduce Alex Wang as our next speaker. Dr. Wang received his MD and PhDs from Johns Hopkins and completed a fellowship with Professor Weinreb in San Diego before moving to his current position in Los Angeles. He has been a leader in allowing us to better understand the aqueous humor outflow pathways that are so critical for developing new MIGS devices and for understanding how to properly use them. He's going to speak to us today on how does the outflow pathway work? Lessons for the MIGS surgeon. Alex.
Thank you, Jeff, for that wonderful introduction. I'm going to share my screen now. Okay, so today we're going to be talking about the biology of the aqueous humor outflow pathways and how that relates to minimally invasive glaucoma surgeries. Here are my disclosures and my sources of research support for this work. So, in this room, we know that in the past 15 years, there's been this explosion of new outflow surgeries, glaucoma surgeries, namely the minimally invasive glaucoma surgeries. And they've really demanded that we understand outflow biology better because they work, but sometimes they're variable. Within this research, there's been a lot of imaging done, first structural and sometimes tracer-based to actually see where the fluid is flowing. Now, each of these surgeries is linked to a particular outflow pathway. We know in this room very well the #1 pathway, conventional trabecular in the red arrow, as well as in #2, the unconventional uveoscleral pathway in the green arrow. Now, what I describe as the third option is the subconjunctival pathway, which really refers to blebs, a direct communication between the anterior chamber and the subconj space. And while this isn't exactly native outflow the way that #1 and #2 are, we use blebs to treat our most advanced cases. So it's actually still deserving of study as a way to improve these surgeries. So for today, we're going to focus on these pathways, mostly 1 and 3. So for trabecular conventional alpha pathway, you can study this structurally using OCT. Many people on this webinar have published on this. Here is our work using anterior segment OCT with automated segmentation to create a three-dimensional cast from a living human eye. But there are problems here, and the biggest problem is the anterior segment real estate is so big, and to get enough resolution to see things clearly, a study like this required over 5,000 B scans to get the final result. So really, this is impractical and far too laborious. So, we asked the question, can you just see where the fluid is flowing? And to do this, we borrowed from our retina colleagues, because if they can take tracers like indocyanine green and fluorescein, put it in a vein, and use an angiographic camera to look at blood flow, why couldn't we take the same tracers, put it in the anterior segment, and look at aqueous humor outflow? So this led to the development of aqueous angiography, for which there was a lot of preclinical work. We're going to skip past all of that, straight to live humans. What you're looking on the left here in every single row is a living normal person getting cataract surgery with ICG in the eye. You see the outflow is segmental, mostly nasal, superior, inferior variable, and temporal has the least, but it does show some. On the right, you've got a 60-some-year-old Chinese woman getting cataract surgery, and this is real time, and you're watching the flow happen. You see it's segmental, you see it pulses if you look very closely, and it's dynamic because regions with and without flow can come and go. Now, we can use multiple tracers, ICG and fluorescein. So now you can actually, within one eye, start with ICG, follow with fluorescein, and you see that the patterns are very similar. And what this creates is an experimental system. You can use one tracer, get the background, the baseline, do something like a surgery, and use a second tracer to see what happens. And that's what we did here first with glaucoma patients getting cataract surgery and trabecular bypass. ICG would go into the eye first, and then inferior nasal, there'd be a region, the red arrows point out, without angiographic signal or flow. 2 trabecular bypass stents were placed there. Fluorescein goes into the eye, and the initial region without angiographic signal or flow was actually improved or rescued back. We call this new recruitment. But there are other patterns as well. Take a look at this patient. ICG goes first into the eye. The red arrow shows you a region without anything going on. The trabecular bypass stent is placed there. You chase this with fluorescein, and again, we get new recruitment. But to stay on label, at least in the United States with these devices, the second stent goes 2 to 3 clock hours south or nearby, near adjacent this pre-existing structure. So when the stent's placed there, you don't see a new outflow pattern. You see the same thing just show up first and brightest. It's like a different improvement. We call this earlier recruitment. And of course, not everything works. Take a look at this eye. ICG goes into the eye first. Inferior nasal, there's a region without signal. The surgery is placed there. We chase this with fluorescein, and no improvement occurs at all at any time point. But the second set, going 2 to 3 clock hour north, is near adjacent this trio of outflow pathways that slowly develops, so that now when the stent's placed there, it just shows up right away, and actually literally at 1 second. So what these last 2 eyes show you is that 2 surgeries in different locations can actually be doing 2 totally different things. And there are different patterns of improvement, including cases where things actually just fail. What's unclear now is which type of improvement is associated with the better IOP outcome. In our case, we had a small cohort, and some eyes would get 2 stents in high flow, some would get 2 stents in low, some in 1 in high and 1 in low. And so really there were just too many conditions. In the future, the studies should really be directed to just placing surgeries in either high or low flow regions, even if just using 1 stent where you can slip it into narrow areas for a direct comparison in terms of whether or not placement matters. I told you I'd talk to you about other outflow pathways as well. Here, uveoscleral outflow. This is my only slide, and really this is based on the fact that we just know less here. There was a MIGS available for a period, CyPass. Many of you have used it. There's been structural studies done here on the left showing these lakes or clefts next to the surgery. What we don't know now is what is really the association with these structural endpoints and IOP reduction in terms of magnitude or duration. We just don't have the surgery available anymore to really collect large volume data. Tracer flow-based studies have been done on the right, but you can see that this is all histology because it's invasive. None of this has been done in live patients. And this is because uveoscleral outflow imaging is hard. It's hard because, number one, it's deep. What that means is that any tracer that goes gets scattered. Also, because it's deep, conventional outflow can appear above it and block your visualization. And then ultimately, uveoscleral outflow is just slow. So this is really an unmet need in terms of developing a outflow imaging technique for uveoscleral surgeries to then figure out whether it even makes a difference in terms of improving our outcomes. And then lastly, I'll stop with subconjunctival outflow with blebs. The old question of how is fluid getting out of a bleb? Is it leaking like a microcydale? Are you using degenerative veins? Is it going back into the orbit, or the old hypotheses of lymphatics? Now, these tracer studies have been studied and done before. The easiest way to do it is you just punch someone in the face, give them a subconj heme, and you can watch the blood resolve in certain patterns. Or scleral tattooing can occur, or you can inject ICG or trypan blue under the conj and actually visualize outflow pathways coming off the blebs. And these pathways did not look like episcleral veins, and so they were hypothesized to be lymphatics. A couple years ago, we got involved in this work by injecting blebs and seeing these pathways actually come up. And we wanted to chase the idea of, what are actually these roads? So with structural study, these pathways would show blind end tips, which is interesting because lymphatics have blind end tips. Lymphatics are also known to have semilunar valves. In B and C, you're looking at transgenic animals with lymphatics that show up, and these bright green spots are actually known valves. Now, in the model that we're talking about, if you create a bleb, you know that the direction of flow off the bleb is red to blue to yellow arrow. So using structural studies in the direction of flow, you can actually see semilunar valves in the conj. So all of this is structural support that actually lymphatics do indeed drain blebs. We wanted molecular evidence as well. Using tracers that we could see and that then we could literally trap. We could then identify on histological section the literal pathway that we're looking at, and then perform co-immunofluorescence showing co-localization with lymphatic markers. But down here, complete lack of co-localization or dislocalization with blood vessels markers, supporting the structural evidence that blebs are drained by lymphatics. To quantify this, most of the bleb-related lymphatic outflow pathways are nasal. I mean, at this point, you're thinking, why is everything nasal? Well, at least in this particular case, we have an explanation, because developmentally, using our rodent transgenic models, we've shown that the lymphatics develop nasally and then wrap around temporally to explain this asymmetry. So fluid and blebs have to go somewhere, long suspected to be lymphatics. Our only contribution at this point is that we've proven that lymphatic hypothesis put forth by others. The current question is whether or not blebs require lymphatics, and if that's the case, how you promote that. MIGS has really demanded the need to better understand and image outflow. New tools have been developed, and hopefully these tools will hold some clinical import in glaucoma care, surgical as in this talk, maybe even medical as well. Thank you.
Alex, great presentation, and again, thank you for presenting, your excellent work to better understand the outflow pathways. I think it'll help us better understand some of the procedures that we're going to be talking about, and we'll be getting back to you during the discussion period. We're going to have Osula Olwaye introduce our next speaker. Osula, are you there?
Yes, I'm here.
Please introduce Dr. Craven.
Okay. Thank you, Professor Wainwright. It is my pleasure to introduce Professor Craven. Dr. Craven is
You have your video? Turn on your...
The host has to turn it on for me. Okay, I think it's on.
Go ahead.
Okay, great. Dr. Craven is an associate professor at the Wilmer Eye Institute. He is the medical director of the Bethesda location for Wilmer Eye Institute and the vice chair of the practice network. In the 1990s until 2013, he was the president of Glaucoma Consultants of Colorado in the Denver area, and he participated in over 100 clinical trials. He served as the chief of glaucoma at the King Khaled Eye Specialist Hospital in Riyadh, Saudi Arabia, from 2013 to 2017. And he has extensive experience with all forms of glaucoma and cataract issues, and is considered one of the premier MIGS surgeons. Please welcome with me Professor Randy Craven. He's going to be talking to us on microstenting. Thank you.
Great, thank you very much. And I'd like to share with everyone my lecture now. All right. Well, you know, so many things have changed over the last years, and I think the world of MIGS, as we heard earlier today, has really caught the eye of a lot of the comprehensive ophthalmologists, and we in glaucoma haven't really spent the time evaluating it as much as many of the comprehensive people have. There's my financial disclosures. And if we're talking about trabecular bypass, it really involves either using a device such as the iStent or the Hydrus, or a no device, but using an excimer laser trabeculostomy. Here, Michael Berlin was kind enough to share with me his Aventurno technique using a very small excimer laser probe that allows you to make basically small holes into the trabecular meshwork, which creates a trabecular bypass without a device being involved. This has been looked at in Germany and Switzerland, and it's been around for quite a few years. They found through a small study that it was more effective than 180 degrees of selective laser trabeculoplasty, and later went on to look at it in conjunction with phacoemulsification, and they found that the pressures ended up in the mid-teens, but this device has not been widely adopted yet. The procedures that involve devices have certainly gone up in volume and interest by, as I mentioned, especially the comprehensive ophthalmologists. The iStent study was started over 15 years ago, and the classic iStent device was really what established our pattern for how we look at MIGS studies today, and really it's helped change in general how we look at studies for glaucoma surgical procedures. The FDA felt that it needed to be done in conjunction with a phacoemulsification, and they wanted us to compare the device with those people having a phacoemulsification alone. And when we first designed the iStent trial, it was a 50-50 randomization. We weren't even thinking about doing washouts with patients because we thought if we'd put it in and see how their pressures were doing at 12 months, that would be good enough. Well, the FDA and the company looked at that and felt we needed to extend it out to 24 months, but then also look at the effects of drugs by washing out the eyes. Now, trabecular bypass today with devices, we have the iStent inject, and recently that's been converted to the W, and the Hydrus are the two most common trabecular bypass stents. But there's new things that we can evaluate from the trabecular bypass procedures, and that would be, can we do it as a standalone procedure? What about if we use a trabecular bypass in conjunction with medications, that is MIGS and meds, and how does that help us? And are there certain patients that we can identify in advance might be more successful for using the trabecular bypass in? As Dr. Wong just pointed out, if we could especially get a preoperative test, that would help us a lot. Now, the iStent inject, as I mentioned, is really the currently available Glaukos device. And that the US FDA trial was a 3-to-1 randomization. And it was a single inserter that had 2 implants that we would place. And then at 24 months, we'd look for the number of people that had a 20% reduction from baseline with their diurnal IOP. That was the primary effectiveness endpoint. Secondary was look at the diurnal IOP reduction. And what we found from that trial is that there was a 75.8% reduction in the IOP at 24 months. And this equated to a 7 millimeter mercury drop in the IOP in the iStent inject group, compared to a 5.4 millimeter mercury drop in the control arm. And you will notice that the baselines were about almost 25 millimeters of mercury, which is important when we're looking at the MIGS trials. What was the baseline IOP? If you go back and take a look at the single iStent in the pivotal trial, we had a little bit higher baseline IOP, and that at 1 year we had better control than we saw at 2 years. So we did see over time that the pressures did drop in control as time went on. Now, the Hydrus study, this was a bit different. It was a 2-to-1 randomization. And we did have a terminal washout, and the primary endpoint was a 20% reduction in IOP at 24 months. Secondary was the mean IOP that we obtained with that. And here you can see the stent going in, and this was an interesting case. The first time we put it in, it seemed to look like it was in the meshwork, and if somebody has a heavily pigmented angle, it's sometimes very difficult to identify where the trabecular meshwork is versus just the anterior ciliary body region. Here you can see after that's in how it's pretty mobile and loose, and it's not staying in position well. That was a clear indication that this probably wasn't in the spot that we wanted it to be. So just a simple re-grasp of the device. And then when you approach it the next time, go a little bit more anterior if this ever happens to you. And you need to also aim it a little bit more towards the sky. That is a little bit of a higher tilt. And then it goes nicely into the canal, as you can see there. And there it's clearly in the in the canal or slim, whereas the first time we had a false passage. And this is something I think that can happen with any of the trabecular outflow devices when people are in there doing that. And if you look at the results from the Hydrus trial, there was a difference between 12 months and 24 months. We saw that those achieving the primary endpoint, there was 85% at 1 year and then 77% at 2 years. So there was a little bit of loss of control, just like we saw with the iStent inject. As far as the mean diurnal IOP reduction, we see that 1 year it was 8.4 millimeters of mercury and went to 7.6 millimeters of mercury at 2 years. Are there further things that we can use the trabecular bypass for to help achieve IOP reduction? As I mentioned earlier, MIGS and MEDS is one option. The other thing is looking at standalone procedures for those patients that are pseudophakic or phakic. And can we use it for any other types of glaucoma? There was a study that was very limited, and it was sponsored by Glaukos in Armenia, that they took 2 classic eye stents and they used it to help achieve IOP reduction in these patients. The mean IOP at the start of the procedure was relatively low, it was at 22.2, and they were on no medications. At 13 months, when the medications had been washed out, the IOP was at 17.1. And when we reached 18 months and they left them on travoprost, which was part of the design of the trial, we were achieving pressures down close to what we saw with trabeculectomy. This to me is something encouraging to think about for our potential future use of trabecular bypass procedures. There was a study done looking at the iStent inject versus Zalcom or Duotrav, which is a fixed combination of timolol with one of the prostaglandin analogs. It was a multi-center design study. Dr. Feo, my good friend, was the author on this. But if we look at the number of people that received a 20% reduction in IOP at 12 months, we see that it was 94.7% in the iStent inject group. And if you use one of the fixed combination prostaglandin analogs with timolol, it was 91.8%. Baseline in these studies for the IOP was pretty similar to what we saw with a lot of the other trials. Now, standalone, I think, is something that all of us have wondered, is that something we can do? And I had good experience with this when I was in Saudi Arabia because many of these devices were approved there. But in Armenia, they took a look at 57 eyes and 30 of them completed a trial. It was a 4-year trial. And they looked at a primary endpoint of 20% reduction in the IOP. The mean pre-op IOPs were at 24. And at 4 years, the intraocular pressure was 14.5. They said that 81% of the patients achieved greater than 20% reduction. So this is encouraging for thinking about it standalone. Now, what about patients that have had some sort of angle compromise, either primary angle closure or they're suspects for it, and you go ahead and do the cataract surgery and then place the iStent into the meshwork? And what this study found is that the mean washed out IOP was at 24.6 for those people undergoing a phaco with the iStent who had a history of angle closure or suspects for it. And at 1 year out, they were 89.2% medication free, and the mean IOP was at 14.8. Now, if you compare that with the EAGLE study, and of course, they're very differing baselines because the IOP was much higher in the EAGLE, but the EAGLE, just which is phaco alone, compared fairly similar to that. So I'm not sure that's an overwhelming, convincing story for using the trabecular bypass with angle closure patients. So in summary, I think the iStent Inject, and the Hydrus all showed a 20% reduction IOP that was significant. 53% that we saw of the patients with the iStent Inject a single. So clearly going to two, as we saw with the iStent Inject, was better. 75.8% of the patients had control at 24 months. And 77% of the Hydrus patients, which was a single implant, but it has a much more broad width that it goes into the angle and dilates the canal of Schlemm. Those were all the FDA trials, so they're well controlled, and I trust those trials for giving us the results. MIGS and meds, we do see that we can hit low pressures if we do combine a prostaglandin analog with one of the trabecular outflow devices. And I think one of the additional pluses that we're getting out of the recent MIGS trial, especially with the Horizon trial from the Hydrus, quality of life, it was shown that the visual recovery was on par with that of phaco. And I think quality of life is going to be a big part of what we look at for our future success with the trabecular bypass procedures. Thank you.
Great. Thank you, Randy. Professor Makoto Aihara will introduce our next speaker. Professor Aihara, it's 1 a.m. in Tokyo.
Yes,
And
right.
You're always wide awake. I don't think you ever sleep.
Yes, but I'm awake very well.
Okay. Well, thank you for joining us.
Thank you. Thank you very much, Professor Weiner and Fabian, for inviting me this exciting webinar. It is my great pleasure to introduce Professor Nobuyuki Shoji. Professor Shoji is a professor and chair at Kitasato University School of Medicine. He attended residency at Tokyo University Hospital in 1988 and was affiliated with the Japanese Red Cross Musashino Hospital in 1991. His leadership positions include Counselor of the Japanese Ophthalmological Society and Director of Japan Glaucoma Society. His talk is microincisional trabectome and cuff dual blade. So please, Professor Shoji. So please.
Thank you for kind introduction, Professor Aihara. I'm so happy to be invited to this first WGA Global Webinars. My talk is about mainly trabectome, and I would like to introduce a new instrument to be used for trabeculotomy ab internum. This is a video of trabectome surgery. When trabeculotomy ab internum is performed alone, a temporal corneal incision is made with a length of approximately 1.7 millimeter. It is better to make the clear corneal incision wider inside to facilitate left and right movement of the handpiece tip. The tip of the handpiece is gently pushed into the trabecular meshwork, then inserted into Schlemm's canal. The incision is carried out along the trabecular meshwork in either a clockwise or counterclockwise direction using the insertion site as fulcrum. A white incision line is regarded as evidence of successful incision. If a single corneal wound is made, a total incision range of approximately 120 degrees is achievable. Reflex bleeding in the anterior chamber and viscoelastic can be carefully removed by using a simple needle. When a standalone procedure is performed, no suture is needed for wound closure. However, when a combined procedure is performed, the incision is closed with an 11 or 10 nylon suture. Presumably, setting the IOP at a high level at the end of the surgery may reduce postoperative anterior chamber bleeding. We performed trabectome surgery on 588 consecutive eyes. IOP decreased from 28 to 50 millimeter mercury. However, it is difficult to maintain the IOP below 15. The success probability when survival was defined as post-IOP less than 21 millimeter mercury was 56% at 5 years. Medication score decreased from 5 to 3.6. It means that patients controlled with full medication involving oral acetazolamide could be controlled with 3 or 4 eye drops after trabeculotomy surgery. Previous reports showed almost same result of post-IOP. Our survival analysis showed the excellent result of the combined surgery group, but 5 years after surgery, success probability fell down and showed almost same results among 3 groups. This superiority of combined surgery group might be due to lensectomy and might be limited within several years after surgery. Success probability of exfoliation glaucoma was excellent within 2 to 3 years. However, it deteriorated more and more at 4 or 5 years after surgery. I would like to give a hypothesis about this deterioration later. We have 3 options for trabeculotomy up internal using devices. There are a few differences among 3. Cahook dual blade has a slicer-like 2-blade structure. The trabecular meshwork can be resected rather than incised in a manner similar to that of trabeculotomy surgery. The KDB is a disposable instrument. Trabecular meshwork could be completely resected. However, I sometimes feel that the footplate of the KDB is tight for Schlemm's canal and feel difficulty to move the footplate in Schlemm's canal. In this video, to prevent rotating the eyeball, I move the footplate of the KDB very slowly. In Japan, small size of cutting device is available. This micro hook were developed by Professor Tanito and Inami Corporation Limited. 3 types of hooks are used in this surgery: a straight hook for nasal incision and an angle hook for temporal incision. Tanito et al. Reported incision at a range of approximately 240 degrees from 2 corneal incisions. It is easy to incise the trabecular meshwork, and we can use this microhook to remove the peripheral anterior synechia before the incision. These hooks can be reused and have a high cost performance. Tanito et al. Reported excellent result in the combined surgery cases. In the part of trabeculotomy surgery, I mentioned about the sudden worsening of success probability in the exfoliation group. However, in the case with trabeculotomy ab externo, the probability in the same type of glaucoma was maintained at 5 years after surgery. I don't know why the results were different, but it's only my hypothesis. Exfoliation material would occluded the collector channel after removed most part of trabecular meshwork by a trabectome. And in contrast, exfoliation material would be trapped by the remaining of the meshwork after the incision of the trabeculotomy ab externo. Long-term follow-up will reveal this hypothesis. At last, in the case with performed MAX targeting Schlemm's canal, the outcome depends on behind Schlemm's canal, that is, collector channels and episcleral venous pressure. So we want to know the way to predict the outcome. We are investigating the episcleral venous outflow. Actually, we often observed the phenomenon that the vein was inconspicuous after the IOP increased and conspicuous after the IOP decreased intraoperatively. And most of cases like this, IOP would be well controlled after surgery. Wade et al. Reported the relationship between the laminar flow of episcleral vein and IOP decreasing. By observing the episcleral venous flow, it would be possible to predict the result after MIGS targeting Schlemm's canal and might be possible to decide an indication for this kind of surgery. My conclusion is described in this slide. The result of the exfoliation glaucoma after trabectomy surgery is interesting. There are differences between that of trabeculotomy of internal and external. This difference might depend on the approach, that is dissection or incision, or other reasons. I want to solve this problem using microhook in future. And I would like to focus on the episcleral venous flow to predict the effect of this kind of surgery and to decide the indication. We are waiting for you all next year. Thank you.
Professor Shoji, thank you. Can you clarify one point? And thank you for bringing to our attention the micro hooks.
Oh, yeah.
Are they reusable? Are they reusable with sterilization?
Reusable after steroid many times.
Wonderful. Thank you very much. Jeff Liebman will introduce our next speaker. Jeff?
Bob, it's a pleasure to introduce our next speaker, Dr. Paul Singh. Dr. Singh trained in Chicago and completed a fellowship at Duke University. Since that time, he has been emerged as a leader in the field of interventional glaucoma during the development, investigation, and adoption of these surgical procedures. He has been a constant panelist and teacher. I look forward to his talk today on microincisional surgery, GAT, and Omni systems.
Thank you so much. Thanks, Dr. Liebman. Thank you so much to Dr. Weinreb, the rest of the WGA. Truly an honor and privilege to be part of this meeting. And I want to congratulate everybody for some great presentations as well. I was asked to talk about viscodilation and GAT using the Omni device. I do speak and consult for a number of the companies in glaucoma space, specifically Sight Sciences, who does manufacture the Omni device. We heard this before. We are very excited and honored to have the opportunity to provide a number of different options for our patients. We can actually tailor our treatment options. And I think the Omni device has been a nice addition to our toolbox. On my desk here of all the different MIGS devices, older picture, you see the CyPass there was an older picture from a few years ago. But why do viscodilation or GAT? What is the benefit? Well, we do know from Alex Wong and others that there is not consistency of patency of the Schlemm's canal throughout the entire 360 degrees, or some areas of collapse. And so that's one of the reasons why we have to consider opening it up. We do know from studies from Hai and Gong et al. That our patients with glaucoma, POAG, have a significant blockage or herniation, blocking the ostia of the collector system as well compared to our normal patients. And here's a nice histology slide on top showing a nice patent Schlemm's canal, excuse me, and then the collector channel here, nice and patent. And down the bottom here with this nice red arrow, you see a herniation. Schlemm's canal is collapsed, blocking the ostia of the collector system as well. And this could be why some of our SLT patients don't respond, some of the stents don't respond as well, depending on where the resistance to outflow is. And so the theory behind the Omni device is really a device that allows us to catheterize, using a catheter, microcatheter, the 180 degrees each way. You can do it both 360 or 180, and allowing us to break those herniations, and then allow us to, as we retract back that thread or that catheter, to release a viscoelastic to really flush the system out. We can also then perform at the same time with the same loader, a ab internal trabeculotomy, where we can go ahead and re-advance the catheter. And then as we pull the loader back to the main wound, we can then perform that 180-degree otomy, and you can go to the other side and perform another 180-degree otomy if desired as well. So again, this is not the only device that does this procedure. Omni is one of the devices that has made it more efficient. We do have the iTrack catheter now by Novamed, and we do have GAT that allows us to perform, or Prolene sutures rather, that allow us to perform GAT. One thing that's nice about the Omni, it has made it more efficient, and I think more efficient for a lot of the surgeons who are trying to get involved in this space. Here's just a video showing us the loader itself, and this is a kind of demo model here, but showing how we advance that wheel allows us to advance that thread. It looks distorted because this is a model that's been kind of used many times. But that's really, in essence, how we utilize this device. So here's a video showing you my technique as well. This is a 360 viscodilation, 180-degree otomy, scoring the trabecular meshwork there and really aiming about a 45-degree angle towards the Schlemm's canal, the trabecular meshwork, advancing the wheel and then releasing it or retracting it back as it releases about 5.5 microliters of viscoelastic over that 180 degrees. Then go to the other side, advance that again to the other 180 degrees as we advance the wheel. But in this case, as I retract it back, I'm not going to come back out. I'm going to re-advance the wheel, re-advance the catheter throughout the 180 degrees, pull back towards the wound to perform my 180-degree otomy as well. Now, these procedures, you do see some reflux of blood, as you heard earlier, with any kind of cutting procedure as well. And I think one of the keys to prevent postoperative hypotony, or hyphema rather, after removing viscoelastic, and this is just a manual irrigation aspiration using Helan GV as the viscoelastic, but really hydrating the wound and over-pressurizing the eye and waiting. I don't decompress the eye right away. I overfill it, fill it, pressurize it, and then what I do is wait for a few minutes. I know it's a lot of time in the operating room. Wait a few minutes, then decompress the eye slowly to allow it to equilibrate with the venous system. And that has prevented a lot of times postoperative hyphemas that can happen with these procedures as well. Here's another video showing you the option of just doing 180-degree only viscodilation and otomy. So you can choose to do 360, or in, let's say, a mild to moderate patient on one medication, two medications, performing just a 180-degree viscodilation and otomy. The key in this procedure as well is, again, to aim towards the nasal angle. Sometimes if it's too parallel, it'll skip off the trabecular meshwork. So you can see here I'm refocusing now, and I'm going to aim and push against the TM there and let that catheter slide into Schlemm's canal and follow the wall of the Schlemm's canal. You see it's dark there, and that shows you're in the canal. As we advance it and then retract it back, I'm not going to fully come out. I retract it back, then re-advance again, and that allows me now to perform my otomy. So I did my viscodilation first to flush the system out, and now I'm going to perform my otomy. And I'm going to go ahead and zoom out here. And then as I zoom out, I'm just going to go ahead and pull back towards the main wound. That allows me then to perform my 180-degree otomy. Now, it's really more about 150-degree otomy. Right at the edge there, you really don't get a full cut right where the edge of the wound is. But you can see here, and I think a lot of us love this poor man's verification of increased outflow. As you fill up the eye with BSS, you see a nice, beautiful blanching, and it increased the venous system, increased outflow facility rather, where you see the whitening. And that's really in the area where we performed our otomy. So it's nice to have that intraoperative verification that we've actually done something positive to the increased outflow facility as well. In terms of data, recently there has been some reports now published, and this is a retrospective analysis from Stephen Vold, Blake Williamson, and others, looking at a standalone indication for patients getting both viscodilation and otomy. And you see they had two groups. One was a pressure that was quote unquote normalized or less than 18, and then higher pressure patients above 18. And in both groups, they found the pressure maintained in kind of at about 12 months down to about the middle teens, around 15. A reduction of pressure we see in the higher pressure group, but in both groups we see a reduction of IOP. So the people who had normal pressure, the goal was to actually get them off of some medications. The people who had higher pressure wanted a reduction of IOP and possibly reduce medications. And they were able to see that in this retrospective analysis. Recently, at the WIO, this is a study called the Gemini study, which is a prospective study looking at concomitant cataract with 360 viscodilation and 180-degree otomy. I was part of the study as well. It was the interim results were presented at WIO, 6 months results. And what you see with the baseline washed out unmedicated IOP around 24, we see at about 6 months down to about 15. So about a 40+% reduction of IOP. What was nice to see as well is the reduction of medication burden in these patients as well. We're seeing about 70% of patients off of medications at 6 months completely as well. Over 80+% of patients on less medication. So in other words, we're seeing not only a reduction of IOP, but really importantly, a reduction of medication burden, which I think is a big definition of success with a lot of these minimally or microinvasive glaucoma surgeries as well. I want to leave you with the last few slides here on my new excitement of combining MIGS devices, combining viscodilation. I'm a musician, so I like to remix things. So remixing, let's say, a stent with some of the viscodilation. Idea is flush the system out, keep it patent with these stents. So at the time of cataract surgery, here's a video of a 180-degree viscodilation, no otomy in this case. And then I'm going to place a hydrous microstent to scaffold the Schlemm's canal, keep it patent as well as help with long-term patency as well. So I'm thinking flush the system out with the viscodilation here. Now I'm going to go ahead and refill the eye, place some more viscoelastic on the cornea. The view is key for all these microinvasive glaucoma surgeries, no doubt. And now I'm going to place my hydrous through that same area where I did viscodilation. And what's nice is it slides in beautifully when you have this viscodilation first as well. So this has been something we've been performing a number of cases on. Here's a video looking at the eye stent inject with viscodilation. This case was more of a moderate patient on 4 medications, so I felt I didn't know where the resistance to outflow might be. So I wanted to hedge my bets by performing 360-degree viscodilation using the Omni here, going ahead and not performing an otomy, just performing on viscodilation, 360 degrees. And once I go ahead and retract it back, I've released that viscoelastic, as you see in that video there. And now I'm going to place my 2 eye stent injects about 2 clock hours apart from each other. And I think what you have to be careful with when you do viscodilate, not to over implant these. So I don't put a lot of pressure when I'm dimpling with these eye stents, because the canal has been stretched open with the viscoelastic. You have to be careful not to over implant as well. With the W, I think you have less of a chance of that implantation as well. And so you see here 2 implants in there. I had a little otomy where I did my viscodilation as well. And I think what's nice about these cases as well is it's nice, that nice verification here where you see that nice flushing of the venous system there as well, which is kind of a nice benefit at the end of the case. So long story short, I do think that this combination is nice and beneficial for some of our patients. We did present this data at Caribbean Eye, and we found you're still going to get to that target range of middle teens with any of these outflow facility type of procedures, but we do see a medication burden reduction. In our case, we found average pre-op meds of 2.4, and only 1 person in this study that we did mild to moderate patients in at cataract surgery time of cataract, only 1 person was on a PGA, so significant medication burden reduction. With that said, thank you so much. For the sake of time, I'll fast forward here, and I appreciate the opportunity, and hopefully we'll have future eye care providers helping us out. Thank you.
Wonderful videos. Thank you very much. Professor Ihara will introduce our next speaker. And again, make sure, please join us in the panel discussion that'll follow the lectures today. Professor Ihara?
Okay. So next speaker is Chervin Sun from Singapore. Chervin Sun is an associate professor and senior consultant at the National University Hospital in Singapore. She graduated from Cambridge University with triple first-class honor and distinctions. As a recipient of the Academic Medicine and Development Award, she completed her glaucoma fellowship at Moorfield Eye Hospital. She has a special interest in the use of glaucoma drainage devices and is amongst the first surgeons in Asia to be accredited in the use of several novel MIGS devices. Also, she has received many international awards from AOS, CRS, APAO, or ARBO. So please, Professor.
Well, thank you very much, Professor Ihara, for this very kind introduction. And I'd like to thank the WGA for this invitation to speak on subconjunctival mixed devices. These are my financial disclosures. Conjunctival filtration surgery is very familiar to us glaucoma surgeons, as trabeculectomy has been the gold standard glaucoma surgery for decades. In recent years, new subconjunctival mixed devices have emerged, increasing our surgical repertoire. The Zen is usually implanted ab internal, while the PreserFlow microshunt is implanted ab external, and both devices protect against chronic hypotony. Let us first look at the Zen implant. Zen surgery looks deceptively easy, but there's really more to Zen implantation than meets the eye. It starts with preoperative mitomycin C injection. Injecting the MMC near the limbus as shown on the left will predispose to an anterior bleb. Hence, you should inject the MMC at least 5 millimeters posterior to the limbus and intratenons, and this will increase the chances of having a posterior and diffuse bleb. And for the beginner Zen surgeon, having any tension when the injector loses contact with the sclera will result in a flick, and on the left, you can see a flick occurring, pulling the Zen back into the anterior chamber. Using a blunt forceps, you can very gently and carefully move the implant into the subconjunctival space, shortening it in the anterior chamber. So now I've learned to slow down during the second half of the implantation process, as shown on the right, and relax the tension from both hands so that there's no lateral movement of the injector at all as it loses contact with the sclera. It's also very important to avoid nasal Zen placement. I used to inject the Zen at 2 o'clock, as shown on the left, but now I inject it more superiorly near 12 o'clock. By injecting the Zen more superiorly, we would avoid large nasal blebs that can cause significant dysesthesia. Initially, I encountered a few cases of hyphema, but intraoperative gonioscopy has virtually eliminated this. As your injector approaches the angle, place a gonioscopy lens on the cornea. I will then pierce the angle just anterior to Schlemm's canal and complete the implantation process. The subconjunctival segment of the Zen should be about 3 millimeters to facilitate a more posterior bleb. It is extremely important that the Zen is free and mobile at the end of surgery. If it's cold or immobile, it's much better to perform primary needling in the operating room than to do so post-operatively at the slit lamp. Scarred blebs can be very daunting for the beginner Zen surgeon, and when this occurs, there are 2 options. I'd like to credit Keith Barton for these videos. You can either perform bleb needling at the slit lamp or bleb revision in the operating room. Though bleb revision with conjunctival pyritomy is likely to be more effective, the out-of-pocket reimbursement environment in many Asian countries means that most patients would prefer bleb needling at the slit lamp as it is less expensive. Hence, some Zen surgeons prefer to implant the Zen ab external with conjunctival pyritomy. And with ab external Zen implantation and with meticulous conjunctival antenons closure, the bleb morphology is more predictably posterior and diffuse, with less post-operative manipulations required compared to ab internal Zen. I've been privileged to be involved in the Phase 4 Zen study when I was working at Moorfields Eye Hospital. And we recruited about 200 patients in this multi-center study. And the results showed that the Zen reduced IOP from 21 pre-op to 15 at 2 years, with a reduction in medications from 2.7 to 1.1. Complications were infrequent and mostly self-resolving, though we had 1 case of endophthalmitis. Currently, there's no prospective study comparing the Zen and trabeculectomy, though this retrospective study showed no significant difference in the risk of failure and safety profiles between the 2 procedures. However, defining success as specified IOP levels, a larger proportion of eyes in the trabeculectomy group had IOP of 14 or lower. Our study reporting the 1-year outcomes of combined phaco Zen in Chinese eyes has similarly good results, with the IOP in the mid to low teens and a success rate of 80%. In this study, we were also the first to report the outcomes of Zen in angle closure eyes. And rarely, occlusion of the implant by iris can occur, though this is easily resolved by laser. We also reported the 1-year outcomes of Zen implantation in uveitic eyes, and we found that it significantly reduced the IOP as well as the number of glaucoma medications. Remarkably, most of the eyes in this study were on 3 or more glaucoma medications as well as oral diamox. And despite this, 62% were medication-free at 1 year. However, we did have 1 case of bleb-related infection, and this was followed by an AJO publication reporting 3 cases of bleb-related infection associated with the Zen implant. The Zen has been in clinical use for several years and is commercially available in many countries worldwide. The new kid on the block is the PreserFlow microshunt, which is made of a novel material called SIBS. Unlike the Zen, which can be implanted ab internal, the PreserFlow microshunt is implanted exclusively ab external. Due to time limitations, I will not go into the details of microshunt surgery, but certainly it is less invasive compared to trabeculectomy, with no need for a scleral flap dissection or flap sutures. This study by Bartley et al. Reported the longest term outcomes of the PreserFlow microshunt, and it showed that it reduced the IOP to the low teens and the number of medications from 2.4 to 0.7 at 3 years. These results are similar to our 1 year's Singaporean data, which we're writing up soon for publication. Preliminary results of an RCT comparing the microshunt and trabeculectomy showed that TRAPS resulted in lower IOP but had more complications. Notably, 0.2 milligrams per mil MMC was used in this study, while 0.4 milligrams per mil MMC was used in Bartley's as well as my studies, which could account for the lower IOP that we encountered. In summary, subconjunctival mixed devices are potentially capable of achieving lower IOP compared with trabecular bypass procedures that we have heard about earlier in the symposium, and judicious anti-metabolite use and post-operative flap management are crucial for the surgical success. Though subconjunctival mix is associated with less complications compared with trabeculectomy, bleb-related infections have still been reported. I would like to invite you to visit our APGS Mixed Interest Group website and do look up for our open access mixed book, which will be published very shortly. Thank you very much for your attention.
Our next speaker will be introduced by Dr. Oluwaye. Osula?
Thank you very much. It is my great pleasure to introduce Professor Julian Garcia Pejo from Spain. He is from Madrid. He has produced and published 284 original research articles and directed 42 theses in the areas of glaucoma and degenerative ocular pathologies. He led his team to become a Spanish National Health Reference Center for Childhood Glaucoma and is a member of the EU Reference Center Network. His team has been internationally recognized with several awards. Professor Garcia Pejo has focused his research on the basic scientific, clinical, and surgical aspects of open-angle glaucoma. It is my pleasure to introduce and to have Professor Pejo talk to us this day about suprachoroidal space as the potential site for glaucoma surgery. Thank you.
Thank you very much for the introduction. And I'm really pleased and delighted to be here in this and participate in this webinar. I would also like to thank Professor Wainwright and Professor Lerner for inviting me here. So these are my disclosures, and they are indeed relevant in this talk too. So we've seen many cool surgeries today, and do you think we should even consider suprachoroidal surgery? Well, I think so. I think there is a room for this surgery. And in this talk, I will try to convince you. So we are all well aware of the problems of the classic suprachoroidal surgeries. It's far from ideal, and we all know that. But suprachoroidal surgery could be an interesting surgical option for some patients with glaucoma. So first, due to the hypotensive potential it has, we are not going to depend on a bleb, and this is hypothetical. There will be a little impact on the conjunctival alterations on the success rate of the surgery. So why suprachoroidal? Well, we have the very high differential pressure between the anterior chamber and the suprachoroidal space and the supraciliary space, around 4 millimeters of mercury at physiological ranges. So this is important. Then, how does the unconventional pathway works? We have three different options. First, the ACUS can use the uveoscleral pathway to the orbital vessels, the uveovortex pathway to the vortex veins, and hypothetically could use this uveo-lymphatic pathway. The good thing is that if we bypass the ciliary muscle, we can benefit from this pressure gradient, and then the aqueous will be absorbed by the choroidal vessels or by the venous plexus. So is it possible to obtain or produce a controlled access to the suprachoroidal space surgically? Over the years, we have many options. Modified trabeculectomy to increase the access to the suprachoroidal space, so the outflows through the unconventional pathway. This combined trabeculectomy, cyclodialysis, many types of modified deep sclerectomies, and of course, ab-externo shunts like the gold shunt or the star flow, and suprachoroidal mix. So if we think about an ideal suprachoroidal surgery, obviously it has to be predictable in terms of IOP lowering, not induce excessive fibroblastic response, and of course it has to prevent hypotony. So we've learned a lot in the last 20 years. So we know that fibrosis in the suprachoroidal space is different from the subconjunctival fibrosis. We know that when we insert a device in the suprachoroidal or supraciliary space, we may have a foreign body reaction. And we know that there are inflammatory mediators and fibroblasts that have an impact, or they have a role in this wound healing process. We know that. And we know that when used ab-externo, mitomycin C could have some beneficial effect, but it's very clear that when you introduce a device in the suprachoroidal space, some inflammation is going to be produced, and wound healing and scarring. So probably we can work on that ab-externo devices, but if we think about surgery with implants, probably the natural evolution is to try to use suprachoroidal mixed devices. So the problem, as you may know, is that first we have to be familiar with anatomy. We cannot really see what are we doing in the supraciliary and suprachoroidal space when we introduce ab-interno a device into that space, which is virtual. So we also have to learn a lot from the CyPass history. So the good thing is that it works, and you see in the bottom right, there's a CyPass implanted in place. So you see how the lake is, the suprachoroidal lake is produced, and it's very clear there is a flow between the anterior chamber and the suprachoroidal and supraciliary space. And also the surgery is quite straightforward. And then we can even introduce viscoelastic, as in the left, bottom left video, in the supraciliary space and suprachoroidal space, and it seems to be quite safe. However, we cannot use it. And the reason is due to the endothelial cell loss after 5 years when compared to phacoemulsification alone. But this is probably related to two things. First, the device position, and also it's very rigid, so it tends to go towards the cornea when implanted. Also, the indication early to mild glaucoma is important. So because in this case, safety is a must. So probably we have to re-evaluate the position and the treatment algorithm. So this is just to highlight how when it's not fully inserted and two or more rings are visible, then it's going to be very close to the corneal endothelium or even touching it. So it's going to cause problems. That is not a trabecular implant in terms of safety. So I'm just showing you an example. This is patients who were implanted with CyPass. These patients were refractory to medical therapy, and they were considered for conventional glaucoma surgery, trabeculectomy. And results are not so bad. In terms of more than 80% of the patients, trabeculectomy was not needed during the follow-up. So, and these results were confirmed in the longer 2-year follow-up. So it's true that some patients, around 70 to 20%, needed additional glaucoma surgery. But remember that this would moderate to advanced glaucoma patients, and we are saving quite a number of them from a more aggressive surgery. And here I'm showing you a patient from this particular paper. So advanced glaucoma, and the patient after 4 years is doing quite well with a pressure around 14 to 16. So, but we cannot use CyPass anymore. So is there any other option? Well, we have one option, which is the mini-jet. So this is not a rigid implant, so it's soft, and this could make a difference. So in terms of, it's going to adapt to the scleral curvature, and this is important. This is an early inserter, so things have to improve. This is obvious, but this is the technique, which is basically very similar to the CyPass technique. So you just have to insert the device through the iris root and bypass the ciliary muscle, and then inject the device into the supraciliary space. And does it work? Well, it works, and this is the paper that has been published this month. And the success rate was very, very high, you will see here. So the IOP decrease was around 40% from baseline, but remember that there was no washout in this particular paper at any time point. So qualified success rate was 76%, and medication-free patients were 55. So obviously this is very early results. We don't really know what's going to happen in with a longer follow-up. But in terms of adverse events, it's very safe. So the safety profile is very similar to the CyPass. Obviously, we hope that the endothelial cell impact will be less. And this is the reason why. So on the bottom, you can see the CyPass is rigid, it's very straight, and it tends to go towards the cornea, as you can see here when it sits. However, with the mini-jet, you see that it adapts to the scleral curvature, and then it tends to move away from the cornea. And this may make a difference in terms of cornea safety. So to end my presentation, I just like to give you some messages. So I think mixed surgery, suprachoroidal mixed surgery, is an interesting option. So I think it's worth to explore. We don't really know if the mini-jet will answer the question or other technique or other device, but I think it's worth to explore. It has potential for the treatment of more advanced cases when you compare to trabecular devices or trabecular surgery. And there are new materials coming and new designs, so hopefully they will also be good and better than the ones we're using now. We have to refine the surgical procedures. We have to be very careful during the surgery. This is probably a surgery for glaucoma specialists. And the key problem is that we really have to learn how to deal with the scarring. And this is, at the moment, is very difficult. Remember that the decrease of the IOP is going to be limited by the scarring and the encapsulation of the device. Thank you for your attention.
And thank you for that wonderful lecture. You know, it's clear to me that the face of glaucoma surgery is changing. And I have the pleasure of introducing our next speaker, Ike Ahmed. And in my opinion, there's no one who has contributed more to change the face of glaucoma surgery than Ike. He has been a pioneer in introducing many of these innovative procedures. And in fact, he was the person who first introduced the term micro-invasive glaucoma surgery, or MIGS. Ike is an assistant professor at the University of Toronto. He's a professor at the University of Utah. He is a skilled surgeon who is among the most experienced in all types of anterior segment surgery. And I would like to also comment that he is a great educator who shares incredible videos from the most complex cases to very didactic information that teaches even beginners, you know, how to introduce these procedures into their operating room. So with great pleasure, I introduce Ike Ahmed.
Bob, thanks so much for your super kind introduction. I really have to owe gratitude to people like yourself. I really stand on the shoulders of giants like you who have just really opened our eyes in glaucoma. So thank you so much. My task is to speak about glaucoma surgery. What procedures do I select? And I do have to disclose a number of disclosures working with a variety of industry partners. I want to take the second, and I appreciate, Bob, what you said about me. I want to take the second just to talk about a friend of yours and mine as well, my mentor, Alan Crandall, who passed away. I think he probably was the best surgical teacher, one of the best surgical teachers that we have seen, and a connoisseur when it comes to glaucoma and cataract surgery, and also a humanitarian. So I just want to pay my respects to my mentor, Alan Crandall, who has helped so many people around the world. When do we consider surgery? Well, this is certainly evolving in the glaucoma treatment paradigm. We've heard a variety of surgical options that exist now that are new and evolving. And I think this makes us reevaluate the role of primary surgery, earlier surgery, and when to combine cataract and glaucoma surgery. This may or may not fit in within the interventional space that we're speaking about, where we try to get patients earlier, get them lower, do it safer, and deal with adherence as well. Different paradigms that are changing. And I think technology has helped us to leverage and move into these spaces, of course, with laser trabeculoplasty, sustained drug delivery, MIGS combined with cataract surgery, and also standardizing microstenting bleb surgery. So what are our surgical choices? It's tough to make choices these days. Some of you are iPhone users, some of you are Android users. Car folks would be maybe preferring the BMW versus the Mercedes. And those of you in the United States have a very tough decision to make come November. We can also argue who is better dressed or who has better hair, long or short or well-groomed or not. These are all debates that exist. Within the options we have within glaucoma surgery, we've covered a lot of them here. I won't replicate them, but I think we can divide them between MIGS, the bleb procedures that can be standardized or otherwise traditional, and cycloablative procedures that we heard about earlier in the program. I think a good reference for the options is the AGS position paper on MIGS published earlier this year in Ophthalmology Glaucoma, dividing MIGS and traditional surgery, bleb forming and non-bleb forming, implant and without implant, and cutting, stripping, dilating, or stenting. A lot of options exist. When it comes to MIGS, we've heard a variety of approaches, conventional outflow, non-conventional outflow, and then subconjunctival outflow can be all considered a variety of ways to go. When we talk about where these procedures fit in terms of selection, MIGS, traditional MIGS in the canal, is more of a medicational alternative, perhaps to get patients off medications and reach a modest target safely. While patients that need a lower pressure that require a bleb move into the more subconjunctival or the minimally invasive bleb surgeries that we have available amongst the new armamentarium. Now, we know subconjunctival surgeries are very potent. The both old and new approaches both rely on the usual outflow system subconjunctivally, may or may not require mitomycin, and have a high degree of potency. The emergence of standardizing bleb surgery by using a standardized lumen can prevent hypotony, as we heard already, and may improve bleb morphology and possibly reduce risks after surgery. We've already heard again, ab internal approaches like Zen and ab external open approaches like the PreserFlow are both examples of subconjunctival procedures. Now, traditional surgery is not going away. We heard about it already. This is the most potent surgery that can be titrated down to low targets. Does have some serious potential risks, however, and makes us shy to move to them earlier. This is where perhaps subconjunctival MIGS surgeries may have a play in terms of better improvement in postoperative intensity and risks and recovery. When a patient needs pressures that are in the more mid-teens targets on lower medication, not so potent, this is where we see a variety of options that exist in the MIGS space, combining phaco with MIGS, uncontrolled juvenile patients with glaucoma, and patients with mild to moderate glaucoma are all potential candidates for MIGS procedures. And we've already heard a dazzling array of stenting, dilating, stripping approaches, still evaluating the role of these in the glaucoma treatment paradigm, but we do see some efficacy with safety with these procedures. These procedures can be differentiated based on IOP target, as we said earlier, with the patients who require lower targets going more into the bleb forming procedures. Let's also remember that combining cataract surgery also affords us an opportunity to also enhance aqueous outflow. While if we're doing this standalone, of course, efficacy is key going to the eye just for the purposes of glaucoma surgery. And this is always a tug of war or the balancing act between safety and efficacy that exists when we choose procedures. The tug of war between trabecular meshwork procedures and subconjunctival procedures. Probably the most important thing to ask when we select a procedure here is the patient controlled? Is their IOP at target? Are they stable? Are they adherent? Are they tolerating therapy? And if they're not, the questions are, do we go with more medical therapy, drug deliveries upon us here, SLT laser, bleb surgery, or trabecular meshwork MIGS are all options that exist. Procedures can be differentiated based on power, safety, postoperative management intensity, ease of use, visual recovery, and of course, cost and reimbursement play a big role. Other factors are whether we're combining this with cataract and glaucoma surgery, what the target pressure, whether it's controlled or not, glaucoma severity, medication tolerability, and the age of the patient all play some role in selecting the right device. This can also be based on drug intervention. For example, a patient with controlled disease at any stage and or mild or moderate disease, often combining with phaco, we typically look at Schlemm's canal as the lowest maintenance procedure. Stenting or dilating, of course, has the greatest safety we've seen. When we want to have a broader access to collector channels, we may go more into a cutting procedure or more of a larger stent or multiple stents as well. And when we're trying to avoid the limitations of episcleral venous resistance, then supraciliary procedures may be an option. For patients who are more moderate to advanced, progressive, or have heavy medications, this is where we go into more of the minimally invasive bleb surgeries. And refractory high-risk patients who need very low pressures need to move more toward a trab or tube. This is my current algorithm. It's a little busy. I'll just briefly describe it in 4 patient groups. Combination cataract, patients who are standalone who need target pressures in the mid to high teens, patients who need pressures of 12 standalone, and patients who need pressures in single digits. Now, when a patient's going to combine cataract surgery, I do like to avoid combining cataract and bleb surgery. In some ways, they're antagonistic with the potential for more wound healing, as well as the potential refractive issues we get with blebs. We want to do the safest, least impactful procedure to cataract surgery and have a synergy of procedures. And this is where I think Schlemm's canal stenting procedures have some synergy and some benefit. On the other hand, patients who are standalone, not going to cataract surgery, need pressures in the mid-teens, we avoid a bleb here. We don't need to go so low. We want the greatest probability of IOP lowering amongst the mixed procedures. We want the greatest access to collector channels, and I think this is where some of the ab-interno trabeculotomy procedures have a role. Patients who need pressures of 12, well, MIGS isn't enough. We need to go bleb. We want perhaps something more predictable, maybe less invasive, faster recovery with a better bleb morphology. And this is where I think subconjunctival MIGS or microinvasive bleb surgeries have a role. And finally, of course, we need to go strong. We need to go powerful. We go to trabeculectomy for patients who need very low pressures. Let's remember, of course, the one variable that we control is surgical technique and placement and the surgeon factor, which cannot be underestimated in the safety and efficacy of our procedures. Thank you again, Bob, for the honor presenting in this WGA symposium.
Well, what a great lecture, and I look forward, Ike, to going a little farther with it in the discussion that'll follow. Our next speaker is Asham Shibani, and
based procedures and maybe give some pearls as to how to pick amongst the myriad of options that we have. I do work with some of these MIGS companies now. Before we start, and I know we've talked about this a little bit, gonioscopy is so critical. If we're just looking for a pigmented band of tissue, this is where we can run into errors. And in this patient, once we compress with gonioscopy just in the office, we see that the trabecular meshwork is, it was actually an angle closure patient. And if we push too hard, you start to get striae. So once you perfect gonioscopy in the clinic, it's very transferable to the OR with some caveats. But I think it's important to get your view first before you start. But when we're talking about patient selection, I think we need to be mindful of who. The personality matters. If there's someone that is looking for this definitive approach where they're going to come off of all medications and the pressure is going to be down, a pressure of 10, there's really no procedure that we can select that's going to guarantee that type of a thing. And so I think a lot of this is also just counseling for the patient. But when you talk about angle surgeries, the anticoagulation is one of the main points for me regarding whether I go the stenting route or a stripping or ablative procedure. If they cannot stop Coumadin or some of these newer antiplatelet agents, I tend to shift toward a stenting option. If they can stop anticoagulation, I think you can use any of the options that are available. And then the goal pressures, we can't be unreasonable. We're not going to get pressures below episcleral venous pressure. So if we need pressures lower than that, unmedicated, it's very unlikely to get that low unless you have a cyclodialysis cleft. And then the compliance with medications matters, and their life expectancy. We're going to treat a 95-year-old very differently than we would a 40-year-old if they have the exact same level of disease. But now let's talk specifically about what some of these devices are. And some of them are accessible in certain regions and some aren't. A single eye stent, I think, is a reasonable adjuvant to cataract surgery for a patient that's already at goal. They tolerate their medications, and they're going in for the cataract. What Ike was showing you is, are you going in for cataract surgery or are you going in for glaucoma surgery? Because if you're going in for cataract surgery, we can then go a little bit lower on the severity of our glaucoma procedure. If you're going in to lower the pressure or reduce medications, then we will end up going with sometimes more invasive procedures that have the potential for lower pressures. If you're looking at some of these larger stents like the Hydrus microstent and multiple eye stents, this is where we can end up having a better chance at removing medications, especially when combined with phaco. And we can really lower pressure as well. So it's useful when you're going in for the cataract, but the pressure or the glaucoma is not under great control. Now we're going to go to more of these larger stripping procedures where we're removing trabecular meshwork. There's different ways to do them. We'll show you a couple, but there might be an advantage to stenting because maybe it maintains this physiologic pump, moving fluid through the collector channels. We wonder about an increased hyphema risk when we remove tissue. And certainly if you remove tissue in the ciliary body band, you can create a very large hyphema. I do find that teaching these to surgeons, and I can tell you with our residents that might have only 20 cataracts, they're also able to learn these. But I find that the goniotomy procedures are a little bit more facile and the learning curve isn't as steep. If you look at viscocannulostomy, where we now are opening up the collector channel system and opening up Schlemm's canal, there might be less hyphema risk, and they lower IOP modestly, but as a standalone, when combined with goniotomies, I think they have some pretty good potential. One, lack of hyphema compared to a large traditional 360-degree goniotomy that we'll show you, just by virtue of having viscoelastic in the collector channel system might make these a slightly safer procedure, but there is more nuance to them. And I think one procedure that we're all very well aware of is GAT, or gonioscopy-assisted transluminal trabeculotomy, where we can achieve 360-degree treatment of the trabecular meshwork. But I'm not sure that's always necessary. I can tell you that probably compared to a 90-degree goniotomy, you would be able to get higher efficacy. Although after about 6 clock hours or half the angle of treatment, I'm not sure you see a dramatic benefit. But these procedures are useful when the pressure is above goal, especially in milder disease states, if they have severe medication intolerance, so you're really looking to reduce the medicines by 2 or 3 classes, and especially useful in secondary open angle glaucomas, pigmentary glaucoma, angle recession or traumatic glaucomas, pseudoexfoliative glaucomas in milder stages, and especially uveitic glaucomas. And if you look at the trabecular meshwork, the reason why I want to bring this up is there are 3 distinct layers. And believe it or not, you can wind up in between layers. Not every device will be placed in Schlemm's canal. I like referring to this video because it's one of the few that kind of shows that this is placement of a Hydrus device. I want you to look, you can see the actual iris processes in front of the device. But based on experience, we know that we're really not in Schlemm's canal. We're probably somewhere in the TM. And so when we go back and we really push a little bit deeper, get more of that insertion tip engaged, there's now more opacity between us and the device. Very minimal pigmentation in the TM. But let me show you a side-by-side picture. The top left was the first placement. The bottom right is the second. And you can see they're just in different tissue planes. There's still something in front of us on the top left picture. We're behind some tissue plane, but it's not Schlemm's canal. And the reason why this is important is with the stenting options, we need to make sure that we're really in Schlemm's canal. Otherwise, they will not work. Now, one technique that we use with our residents actually is this BANG, or bent ab internal needle goniectomy. You can use it with a 25 gauge needle, has to be at least 5/8 inch or about 1.5 centimeters, and bend it at maybe a 75-degree angle, almost like a reverse cystotome. and it can be applied to do a partial goniotomy. Again, it would be a disposable option, especially when someone's looking to get involved in doing angle surgery. I think this is a very reasonable approach. We've looked at this to make sure that we can remove the trabecular meshwork, and on pathology we can. And if you look, our pressures in a mild to moderate glaucoma patient population undergoing cataract surgery, pressures at around 6 months right now, 17 down to 13 with the reduction in medications. And I think if you're really looking to treat these higher pressure situations or secondary open angle glaucomas, as we've shown before, doing the GAT surgery where we create a goniotomy, then we thread a suture, 5-O-proline that's had mild low temp cautery to round the tip of the suture, and we can cannulate for 360 degrees. As you see the back end of the suture coming out, we can then pull on both ends of the suture to strip the trabecular meshwork off of the canal. Now, I want to talk very briefly about some pearls with these surgeries. For one, they do have efficacy as a standalone procedure. They have relatively low complication rates when you know how to manage the hyphemas. And it can even be done in patients that have had prior failed filtration surgeries, and certainly in pediatric glaucomas. The one thing I want to talk about is the goniotomy flaps with GAT. In general, you will have a flap of TM. You don't have excision of TM. So there is the potential that these flaps can fall back against Schlemm's canal and lead to a sudden pressure rise. So it's something to be aware of. The hyphemas can be significant. This was a patient that had a hyphema just hours after the procedure. Ways to avoid this now are to actually pressurize the eye. I used to leave viscoelastic in the eye. That's the picture on the left. You can see about 2/3 of the eye have viscoelastic very clear up top, and now I have a large hyphema down below. Now, it resolved with time in this patient, but if you leave the pressure at the end of the case around 25 to 30 millimeters of mercury, you don't always need to use much viscoelastic to prevent large reflux hyphemas. But the other thing to be mindful of is there are issues along the iris bridging vessels. If we treat a full 360-degree GAT procedure, can sometimes leave areas of iris ischemia. If you look at the pupillary border on the right side, you see that the rough is gone. And now this area is very atrophic and ischemic. And the reason why that happens is there are these peripheral iris vessels that feed the leaflets. And there is a chance when we strip, depending on the patient's anatomy, that it can actually break some of these bridging vessels. That, I think, is more responsible for the really catastrophic hyphemas than what we see with the typical reflux hyphema. And these are the patients in which we see some mydriasis and loss of the pupillary rough. Now, it happens in probably less than 5% of patients, and I think doing partial goniotomies really limits the occurrence of this. But postoperatively, steroids. I don't believe in treating with steroids unless there is a layered hyphema. Otherwise, you're not really treating anything. Steroids are for iritis and fibrin prevention. Once there is no more layered hyphema and it's a microhyphema, we start to rapidly taper steroids because there can be a very aggressive steroid response in these procedures. If you start to see early peripheral anterior sneaky eye, you can use pilocarpine. It's also exquisitely good at lowering the pressure post-procedure if you do have a high pressure. And I stop glaucoma medications immediately. We do not want reflux to worsen the hyphema. And we touched on the mydriasis. But what do doctors need to know? You don't need to do every procedure. I think it's reasonable to have one stenting option and one ablative or stripping option. You need to make sure that you visualize the angle. And if you're going to stent, make sure it's in the right spot. Otherwise, it's not going to work. And the patient needs to know that these canal surgeries can increase the chance of reducing their medications. Now, whether you do them or not at the time of cataract surgery is up to you, but I think at least in the US, it's becoming more and more standard of care that glaucoma patients, especially on medications, undergoing cataract surgery, are getting some type of MIGS procedure. The bleeding can occur early or late, and let patients know that the pressure will not stabilize until weeks out after stopping the steroids. Just another picture of doing this if you want to get involved into angle surgery. Thank you so much.
Great. I'd like to invite the session chairs and speakers to all come online here. Mute yourself unless speaking, but let's see your faces. So that was an amazing session. And one can see why there's so much excitement for the glaucoma surgeon today. I think there's nothing more exciting in all of ophthalmology than glaucoma. And there's no one who's better positioned to share that excitement than all of you, the glaucoma surgeon. So let me just open up a question. I'll ask it first to Alex, but I'd like others to comment. You know, one of the exciting things about cataract surgery was the transition that was made from picking an intraocular lens that would estimate, you know, what the correction would be to the fine tuning of that. Alex Wong, you know, the vision that I've always had for glaucoma surgery is being just like the cataract surgeon, doing some preoperative testing and in advance selecting a device and selecting a location for that device based on the preoperative testing. What do you think about the prospects, you know, for doing something like that to fine tune our glaucoma surgery, improve our results, and improve the safety?
I think that your vision is really a perfect scenario. And where that comes from is with exquisite understanding of what's going on. I mean, with cataract surgery, we have a clear view of what we're doing during surgery and what the lenses ultimately actually provide. And what we're seeing here in glaucoma surgery is that, you know, we go into these waves. I mean, angle surgeries, these other approaches had been considered years before, and then we then evolved to blade-based methods, and now we're kind of going back. And as a part of that clinical change, we're reopening the box to understand the biology again. I mean, that's the focus here. We could achieve that, but we have to literally understand how these surgeries are working and what happens to them over time, not just initially, but after as well.
Great. And I'd like to hear other comments from the panel.
Yeah, I would just echo, and I'm so excited the work that Alex is doing, and Bob, you've kind of been inspirational in pushing this, understand the diagnostic side of either predicting success or patient selection or placement. I think that, you know, location, I think, does matter. I think the physiology shows this. Understanding where, though, is still a mystery, and the information we can get preoperatively can help us. What's interesting with MIGS is we see, if we look at the actual data, we see a variable response rate. You know, some patients do amazingly well, others have minimal impact, and then we say the averages are okay, right? And we say MIGS works okay. And our job needs to be able to kind of segment out and have a patient selection process and a surgeon selection process that enhances the responder rate. And I think that's going to come by understanding what's happening distal to the trabecular meshwork, and again, getting more predictable placement and addressing wound healing. Those are some of the things that we're missing.
Great. Randy Craven, I'd like you to comment on, you know, your experience of using a trabecular bypass procedure in a patient who's already had standard surgery. For example, a trabeculectomy, a glaucoma drainage device. What do you think? Yeah. Is there a role?
You know, I had good experience with that when I was in the Middle East in Saudi Arabia, because they approved the trabecular bypass to be used standalone. So I had a chance to do that. And what was remarkable to me is I had some people that had scarred down because there's significant scarring that the Saudis have with trabs or tubes. And I would go in and try the trabecular bypass on some of these people because there was very few options. And occasionally, it wasn't a high responder rate, but you would get significant pressure reduction. And again, it would be nice to have some preoperative tests to do to tell us when that's an option. I guess it's not too dissimilar from what we saw post-trabeculectomy using ALT in the past with some of our other studies.
Great. And similarly, I'd like to you know, hear from Professor Shoji.
Yes.
And can you comment on that as well? You know, performing some of the beautiful surgeries that you showed, these incisional surgeries, you know, with internal blades or the micro hook that you described.
Mm-hmm.
And you do these procedures in patients who've already had trabeculectomy or glaucoma drainage devices. And also, what about patients who've had laser diode, cyclocoagulation?
Mm-hmm. Mm. Yes, I do. I do cyclocoagulation. after refractive glaucoma.
You can do an ab interno procedure with trabeculectomy and glaucoma drainage device. Is that?
Oh. Maybe I didn't do ab interno after trabeculectomy.
Not after. Not after. Paul Singh, how about you? What? Any experience with that?
Sorry, I was on mute again. Yes, that's a good point. We have had experience using both stenting. We are part of a study that was looking at stenting post failed traditional glaucoma surgery. And we have experience using some of these cutting procedures and viscodilating procedures. I think it can work. Not every patient, of course. Depends on outflow facility. The distal channel is completely atrophied, so severity of disease. But yes, there is a possibility. I think it's worthwhile, especially if the conjunctiva is unhealthy and you don't have any real estate to perform, as an external surgery. I think it's worthwhile to consider, if you have a nice open angle, to go back and try to open up the drainage system conventional pathway. It's possible.
We typically perform many of these ab interno procedures in nasally because of access. And I'm going to ask Chelvan Singh, any suggestions for perhaps having access to other areas rather than just the nasal areas? Infranasal, supranasal. Can we do it can we do these procedures somewhere else? You had mentioned in your lecture, for example, with the ab interno Zen, that typically you were doing it in an outer quadrant and you moved it to a 12 o'clock. I'm wondering, with some of the ab interno surgeries that we're discussing, any advantage to going to another area? And suppose you do it nasally and it doesn't work. Is there any option to go to another area and do it again?
Yes. So I've had some experience performing hydrous implantation inferiorly, sometimes when it doesn't go in nasally. I think that's possible if you ask the patient to look downwards or to tilt the chin downwards, and it can go in inferior temporally as well. The other thing we can consider using also is using one of the indirect gonioscopy lenses with the eye upright. And you might be able to put in the lenses, the devices in places that you wouldn't do with a direct gonioscopy lens.
Right. Thank you. And Dr. Feju, I mean, what a great lecture on the going into the suprachoroidal space and again, it's a very exciting space. And it's good that it hasn't been abandoned after the experience with withdrawal of a prior device. What about doing one of these procedures in eyes with failed trabeculectomy, eyes with failed GDD, or what about failed ab interno procedures of the trabecular meshwork? Would you ever go into the ciliary muscle and attempt to lower the intraocular pressure?
Yeah, well, thank you, Robert. The problem with the experience that we had with CyPass in CyPass surgery or suprachoroidal surgery with devices in cases after failed trabeculectomy is that the results were a bit disappointing, to be honest. So I don't think they have a role in these kind of patients, but I've used the devices for more advanced glaucoma patients. So let's say I was suggesting that with bad conjunctivas, this is an option. And also after failed eye stents. So I think there is a role for this and there is a potential for these kind of devices.
Great. Arshay, I'm curious. I mean, you created some scenarios and gave us some great tips. Which of these procedures would you consider if you need very low intraocular pressure, the lowest intraocular pressure?
Yeah, if you're going to go low, then we're talking subcon surgery, unless you go the suprachoroidal route. But I think for just consistency, it's going to be subconj, and then you're looking at, when you're talking newer devices, Zen or PreserFlow there. And if we could create a good controlled cleft, we can certainly get that low, but that's playing with fire.
How often can you get single-digit pressures with these procedures?
You know, with the Zen procedure, I'd say it's probably 10% of the time, and it's in a very select patient population. We've seen it in high myopes with thinner scleras, and sometimes those are the patients that we're looking at. I don't want to open up a huge can of worms, but I'm not sure that there's a lot of patients that really need single-digit pressures. I think a 14 medicated pressure is very different than a 14 surgical pressure, but maybe we don't want to go there yet.
Okay. Great systematic approach to these procedures. And I'm just wondering, you know, in the hands of such a skilled surgeon as you, how predictable are these procedures? Can you comment on predictability, and are some procedures more predictable than others?
Yeah, this is the age-old question we try to figure out. And I would probably compare to, for example, back in the phaco era, where I think we would argue that the phaco surgeon made a big difference to the phaco outcomes. And I think we're probably now seeing that, you know, when we look at our university center, that residents do almost as well as our staff do with phaco. We're not there yet, of course, with MIGS in terms of the exact placement, for example, whether it's a subcons procedure, whether it's a trabeculometric procedure, whether you have the stent in exactly perfect at the right location. So, I mean, although I don't have hard data to support that, I will say that we have seen learning curves. For example, we just showed and just have a peer review paper in progress where we look at learning curve, where we see the results, for example, with Zen are different when you look at the surgeon's first 20 versus their last 20 over a multi-year period. So there is something to experience, there's something to learning. These webinars are fantastic to share these skills. And we do have some now evidence, I think, that learning curve plays a role. We look at our resident versus our fellow and staff experience with MIGS as well. And although we haven't published this, I think we do see a bit of an edge with our staff. This was particularly important when Arsham was a fellow with mine because the difference was huge.
Yeah, I just could never really get them off medicines, and somehow my surgeries worked. It was incredible.
That's why you put the stents in the superciliary space.
Yeah, that's right. The first suprachoroidal shunt.
It worked though.
Yeah, you know, Paul, you presented the mixed procedures where you're combining different types of devices. I'm wondering about the health economics of that. You know, even in developed countries, it seems like it might be pretty costly. And you know, so much of the world now, and so much of the glaucoma in the world is in countries where, you know, health economics is a real issue. Can you comment on that?
Yeah, it's a great point, and we don't want to minimize the impact of cost on healthcare as well as the patient. But I will say, in the patients who, let's say, have uncontrolled pressure, not compliant, or let's say are on multiple medications post-surgery, the impact, and again, I don't have great data right now to support this, but from reading and a lot of other data sets out there, if patients are on medications and still progressing because of non-compliance, then the cost of the healthcare system for doing a procedure later on, like a trab or a tube, and then the other comorbidities that occur post surgery, I think can add cost as well. So the idea is to upfront add more cost, no doubt, but then hopefully on the back end, protect these patients from progression, compliance issues that could lead to a higher cost later on. That's the premise behind it.
Right. You know, SLT is still it's widely performed. You know, in certain areas of the world, it's performed more than in other areas of the world. And one of the things I've often wondered about is the success of trabecular meshwork-based surgery in eyes with SLT versus eyes without SLT. Randy Craven, any experience, any comments on that?
Yeah, I think actually Ike has a great video of that he's shown where he was doing canaloplasty ob externo years ago, and it was somebody that had ALT versus SLT, and he could show the difference in what happened to the canal. And I think ALT is more thermally destructive. Personally, I think that the SLT is not that destructive, and I haven't found that it makes a big difference with the people getting either the iStent or the Hydrus. Ike, your comments on that?
Yeah, I agree with the ALT question. The SLT question is a bit controversial. And unpublished data, when we look at some of these big phaco-mix studies, shows a little bit of and I hate to use the word trend because it's not really a scientific word, but maybe if we had more numbers, maybe we'll show it, where perhaps the patient with SLTs didn't do as well in terms of response. Again, this is not statistically significant. The numbers were too small. Anecdotally, you would think that would be similar. It's just that in my population, pretty well everybody gets SLT. And so it's really hard to distinguish between those that have it and have not. Considering the lack of significant structural changes in the canal with SLT, one would think that there would be less of an issue, but there could be other mechanisms at play. So I think we shouldn't stop doing laser trabecoplasty. If anything, we're doing more primarily. And if you have an option to choose SLT versus ALT, then perhaps, I say only perhaps, because again, this is only more anecdotal, that SLT may have less impact, at least mechanically, what's happening in the canal.
Great. I want to conclude just with Ike, I'm going to keep you up again here. You shared your vision several years ago with MIGS, and it's something, you showed us, great prescience and foresight. And I'm wondering if you can share a vision for the next 5 or 10 years with all of us for glaucoma surgery. Where's it going?
Well, I can share my vision in 30 years, which is we'll be doing no glaucoma surgery because we'll have non-surgical ways to rehabilitate the nerve and using stem cells. In the next 5+ years, I think I'm really looking forward to the work like of Alex and others when it comes to imaging and understanding diagnostics and pairing diagnostics when it comes to some of the mixed procedures. We're under the elusive wound healing issues around there. And I would say that I think supraciliary space is making a bit of a comeback. We do miss it. I mean, we do, of course, understand the challenges we've had, and Julian presented it well. I think that space will come back, and I think we'll find an additional place in that area there. But I will say that when I was a bit younger, Bob, I think I was very optimistic. I think as we get a bit more along the glaucoma chain of events, we get a bit frustrated because of the limitations we have with all our surgical options, including in MIGS. And I think that we have understood a bit more what our limitations are. There's significantly a role for this, but I think, as I said earlier, if we can figure out the patients who do the best in them, if there's a third of patients we do that do really, really well, we need to find a way to unlock that patient and know who that patient is. And I think the answer is going to come on the diagnostic side, most importantly. So those are just some of my thoughts. I mean, it's a slow-moving train, of course, and we're in it for the long haul. And I just think that the thought of it is important. We must remember, of course, that our current standards of therapy, medical therapy with poor adherence, is not ideal either. So that drug delivery is exciting. All those things are happening, but I'm not as much of a visionary as you, Bob. Honestly, I'm not. I'm a pretty simple guy. So those are my thoughts. Those are my thoughts to share here.
Well, great. Again, there's never been a more exciting time to be in glaucoma. There's nothing more exciting in all of ophthalmology than the space that's being created by all of you, the glaucoma surgeon. I mentioned earlier, we had about 2,700 individuals registered. However, we have some additional numbers now that I find staggering. We've also been viewed on Facebook and YouTube, and we've had over 8,000, that's 8,000, over 8,000 viewers for our program today. I can't imagine anything engendering, more excitement and more viewers than the topic that we discussed today. Again, I want to thank our sponsor, Allergan. I want to thank the host, our partner, NTOD. Also, a big shout out to Fabian Lerner, the president of the World Glaucoma Association, for sharing the vision of an educational series. Fabian, it takes a lot of courage to be a leader, and thank you very much for your courage. I want to thank our staff in Amsterdam, and most of all, I want to thank everyone around the world. With 8,000 viewers, we represent at least 6 continents. I'm assuming it's only 6. There might be 7, but I only know of 6 continents now that we've engaged, in this meeting. And I'll turn the rest of the program over to Fabian Lerner. Fabian?
Hey, Bob, can I ask one more thing? It's a tradition on these webinars to everyone turn on their webinars and take a group picture. Can I ask if we could do that?
Let's have, the speakers, faculty, please turn on your everything here. This is a historic, it's our first WGA. It's probably the largest, webinar online meeting that's ever been held. It might be hard. We probably need some support from NTOT here. Any suggestions?
We got a few on. We'll take a group picture here now. Everyone smile.
It's our first WGA. It's probably the largest. Great. Fabian?
Sure. I'm going to share the screen. And of course, a big thank you. Thank you for this amazing program. And the big thank you goes to the program organizing committee, the program director, the chairs, and of course, the speakers. The WGA executive office that has worked so well and so hard for this program to be such a success. The NTOT officers and the IT team, kudos to them. They worked very, very hard to bring this to a big success. Thanks to our sponsor, Allergan, and to our supporter, Iridex. And of course, thanks to the audience, as Dr. Weinreb said, we had more than 8,000 individuals watching this webinar. And these came from 137 countries around the world. So we want to hear you as well, and your opinion matters. So please take a picture to this QR code, and that's going to take you to a survey. This is a very short survey. We want to hear your opinions in order to better serve you. And stay tuned for the next webinar of the World Glaucoma Association. That's going to be in December 19th. And the topic is going to be on glaucoma diagnostics. And again, this was the launching of the WGA Global Webinar Series with our first webinar on glaucoma surgery. Thank you very much.
I recommend micropulse laser therapy to a variety of patient types within my practice, but fundamentally, this is a treatment option for patients who are unhappy or uncomfortable on their current glaucoma medications and who are also uncomfortable with the idea of traditional glaucoma surgery, which may have higher risks. Many patients are appropriate for micropulse laser, whereas some glaucoma treatments are limited to only mild, moderate, or severe glaucoma. This laser applies to all glaucoma spectrums, including patients who have not had surgery or have had surgery. So it's very versatile. I think it's on the table for anyone whose glaucoma is not optimally controlled.